residents. Good morning, everyone. I'd like to welcome all of you to our Recovery Residences 101, hosted by WAQRR. A bit of housekeeping stuff to go over here in the beginning. I know this is a little bit longer of a presentation. Going to take roughly 4 hours, give or take a little bit, but it as much interaction I guess I want to say as we can get throughout this thing, the better. I know 4 hours can be a lot of time if we just have presenters that are here just presenting directly towards you guys. If you guys have questions and comments that come up during our presentation, please just go ahead and post those in the chat. And either Sarah or myself will do our very best to get those answered as we cover all of the material today. I'd like to introduce the individuals that are joining me here today. I have Alan Mua, our board chairman for WAQRR, and also a recovery residence operator up in Skagit County. Also joining me today is Karen Carmen, who also sits on the WAQRR board of directors, and she's also a housing director with Hope Street out of Walla Walla. And also joining us today is Sarah Carr, our assistant of accreditation, and Sarah resides up in the Snohomish County area. And with that, I'm going to go ahead and turn it over to Karen.
Great, thank you, Jason. Sarah, do you want to go ahead and start the PowerPoint? So thank you, everybody, for being here. That's awesome. In case you don't know what WAQRR stands for, it's the Washington Alliance for Quality Recovery Residences. Sometimes that we just say WAQRR and we don't explain what that means, but that's what that is. You heard who's here, who's speaking, so we'll go past this one. Let's go to the next one, Sarah. So in the past, Jason, because we have a large group here, do you want people to just put that in the chat? Yeah. So if you can throw in the chat your name, organization, if applicable, and location. And if you want to put what draws you to recovery residences, that's great. Recovery housing. And then here is a quick overview of the day. We've done the introductions. We'll just go briefly over who WAQRR is and the work that we do. We'll get into fair housing, the levels of care, and the NAR story. Then we'll have a lunch break, which is great. And then we'll come back and we'll do some current topics, and those kind of adjust. Sometimes there's an opportunity there for you guys. If there is something that is pressing and you're curious about, you can always bring that to us there. We'll also do the accreditation process, explain specifically how that goes, and then open up a time for you guys to ask questions. So let's go ahead and move next. So primary activities of WAQRR. There are 3 primary activities of WAQRR. One is the accreditation, and we're going to go into that into much more detail later in this, but really the accreditation is an opportunity for you to become an accredited home through WAQRR. There's a process for that, and it's a 3-part process. And again, Sarah's going to go into that in more detail later. But that is, it is the process looking through your documentation and your policies, then looking at an interview, and then there is a house inspection. And that's kind of the 3 parts that happen with that. Great thing is, you guys, WAQRR has a really great accreditation team that will help somebody through that. So it's not like you're plugging through that all by yourself. You'll get the support. Once you're accredited, you get to be on the Recovery Residence Registry for the Washington Healthcare Authority. And that's really valuable for people who are looking to find a recovery residence. Then they can go to that registry and then you're listed there. Next thing is support and networking. This was so valuable. I am a recovery residence operator, and I've been open for just about 3 years now. But when I was up and just getting started, that support from WAQRR was so valuable to be able to answer questions when I didn't know how to go about something. When I had questions just about setting things up, super valuable. that networking, once you become an accredited Walker home, you're a part of the family of homes. So it gives you an opportunity to network with other homes, to talk with other providers, and to learn from them and to share and kind of grow together. And then the last thing is that professional development and training, which is like what we're doing right now. Yay. So there's tons of trainings. When I first started, I took every single training I could possibly take because I wanted to just get as much knowledge as I could. Those trainings are offered pretty frequently. And the great thing is, if you can't jump in on the training and you see something like, oh, there's a training on conflict resolution and I missed that, if you go on the WAQRR website, you can look at there under the More tab, I think it's where it is. It's under recordings, and you can go back and watch something. So maybe there's something like that, or if there's something on return to use or MAT or mindfulness, something that you really need some more training on, there's that opportunity for you to get a hold of that there. So that's the activities. I think we're jumping into what is a recovery residence, and I think that's Alan.
Yeah, I want to do that. Hey, before we do that real quick,
Yes.
Karen, I wonder if you wouldn't mind just kind of like reading through the chat a little bit and just kind of so just quickly kind of introducing us to the folks who are replying and so on. So we kind of get it, everyone gets a sense of I don't know if everyone's like me, sometimes it's hard to kind of read and listen at the same time. So let's just take a minute to maybe if you wouldn't mind just kind of what did some people write? Just tell us who's here.
You want just names. Okay.
Yeah, names and maybe where they're from, that something like I don't know. Just be kind of fun to just sort of
I
see who's
see
out there.
LaShonda, Rhonda, Rosenloff. I apologize anybody if I butcher your name. Rob McDonough from the Healthcare Authority. Washington Care Connections. Marie. Why does everybody have complicated last names? Where's Smith?
We could just do first. We could just do first
Okay.
names and where they're from. That'd be great.
Marie, regional SUD leader for Region 3, North Sound. Liz Kearney, Clark County Community Services. Michaela, Community Action in Skagit County. She's always working with clients who need housing, and that promotes them helping in their recovery. That's great. Holly, supportive house manager. Rhonda from Olympia Sober Housing. Kelsey, Jefferson County, Kitsap, okay, behavioral health. Jacob from Snohomish. You have lots of clients who have questionable experiences with recovery houses and would like more information how to find reliable ones. Well, you're at the right place. That's great. Narissa from Washington Care Connections. Kim from Poulsbo would like to bring recovery residences to their city. Monica, here learning a love for all things recovery. Advocates Recovery Services, Snohomish County. Barry Bacon, Hope Street Project, that's out of Colville, similar to our name. Advocates for Recovery Services. David, Northeast Washington Alliance Counseling Services, Star from Harps in Mason County. And that's it.
Great. Hey, thanks a lot. Thanks. I really appreciate that.
Yeah.
You have a future as a Vanna White kind of a
Yeah.
figure. If anyway, really, that's great. It's helpful just for everyone to kind of know who else is in the room, especially when we want to really make this as helpful as possible. So it sounds like we have a number of folks who we call operators. I don't like the term operator because it sounds sort of smarmy, but we use the term operator instead of provider because in Washington, provider has a really specific meaning that typically has to do with clinical services and so on. So when we talk about housing operators, that sort of distinguishes that group of folks from folks who we might call providers, even though we are providers of recovery housing. So anyway, just to confuse things a little bit farther. So a number of those folks on the call, and then it sounds like a number of folks from agencies who are just interested in really quality recovery housing and wanting to know more about what that looks like. So that's great. Well, we thought it's always helpful to start with the definitions. I'm going to turn my camera off. I'll turn it back on. We're a little bit more interactive, but it'll help me follow notes and stuff better. So So you're not missing out on all that much, is what I'm trying to say. So this definition comes from SAMHSA, and I'm going to read it and kind of annotate it a little bit. So the reason why we thought we'd start with the definition is because the definition of recovery residences or recovery housing is more specific than other kinds of housing that you might be familiar with. And so just so as we sort of start out the day, so you can be aware of what we mean when we're talking about recovery housing. So recovery houses or recovery residences are safe, healthy, family-like, substance-free living environments. So we love the word family-like because when we're talking about homes, they really should be a lot like single-family residences as opposed to kind of clinical settings or hospital settings. Jason, I don't know, we're seeing your presenter view now, so I don't know if we want to pop back into the mode we were in. That might be helpful. But so anyway, so they're family-like environments, and they're substance-free. And so that really is what distinguishes us from other modes like permanent supportive housing. And we're absolutely supportive of the whole continuum of care. But what we're talking about when we're talking about recovery residences is places where people have chosen to live who want to pursue an abstinence model of recovery where they've committed to not using substances while in their living environments. So these environments, they support individuals in recovery from addiction. While recovery residences vary widely in structure, all are centered on peer support and a connection to services that promote long-term recovery. So another way of saying that is the tent of recovery residences is very wide. So we are not in the business of telling people what philosophy of recovery they should abide by when they're running a recovery residence. But as long as we can agree on some of the big ideas around, hey, that the secret sauce of recovery residences really is peer connection and connecting people to one another in an environment where that connection, as you've heard people undoubtedly say many times, the opposite of addiction is not sobriety but connection. So we're trying to help people find that level of connection. And in order to pursue long-term recovery. Recovery housing benefits include benefits individuals in recovery by reinforcing a substance-free lifestyle and providing direct connections to other peers in recovery, mutual support groups, and recovery support services. All we're trying to say there is that these homes should look different from a boarding room down the street or a hotel, or there should be, when you walk into a recovery residence, you should be able to tell that, okay, there's a recovery environment here. There are things on the wall that show us that people are that have services available to them. There's maybe meeting schedules, all those kinds of things that are always pulling people deeper into recovery community. So continuing on, substance-free does not prohibit prescribed medications taken as directed by a licensed prescriber, such as pharmacotherapies specifically approved by the Food and Drug Administration, FDA, for treatment of opioid use disorder, as well as other medications with FDA-approved indications for the treatment of co-occurring disorders. So all of that to say that substance-free is a nuanced term. What the substances we're talking about specifically are alcohol and other mood-altering substances that people are using outside of kind of medically approved uses. So they're not under anybody's supervision. So just to be super clear, to put a finer point on that, recreational use of marijuana, for instance, wouldn't fit underneath the umbrella of the homes that we certify in WAQRR and that are considered recovery residences in the state of Washington. So any questions about, just kind of pontificated there a little bit, but any questions, feel free to just drop them in the chat if there's anything in there that you're kind of curious about. You saw the agenda the rest of the day. We're going to focus in on some of these things, but just again, in the way of foundation, want to make sure everyone's kind of clear of what we're talking about when we're talking about recovery residences.
Alan, did the screen return to looking normal again? I
Yes, sir.
apologize.
We're
Okay,
looking at it. There's a
perfect,
hand with a house in it, and
perfect.
so perfect. Thank you. All right. If I'm gonna, again, Sarah has our permission to interrupt anytime someone comes up with something they want to know or expand on. Otherwise, let's keep rolling. So we want to just talk about real quickly the legal basis for recovery housing, and specifically fair housing is kind of the language that we use that kind of allows us to exist in our field. And so there are several. The one we're going to really focus on is the very first one, but the Fair Housing Act of 1968, the Rehabilitation Act, kicks in if an organization is directly federally funded, and then the ADA, especially Title II of the Americans with Disabilities Act, kicks in when there's a direct sort of government provided housing. They're going to be a lot more. There's going to be a lot more need to pay attention to the ADA. So we typically don't interface much with the ADA because we typically operate single family residences. And so we're going to talk about that in a minute. But the big idea there is that we, a municipality or others can't require homes to abide by policies or city ordinances that a single family residence wouldn't have to abide by. So that's a protection that's afforded to us by the Fair Housing Act. So let's go to the next slide. And
Alan, we have a quick question here.
Great. You bet. Read it.
It's from Kim. Is it possible for a recovery residence to be classified as supportive housing? What if some services were brought in-house?
Yeah, so we're going to talk about levels of care in a few minutes, and maybe that's where that fits. So we absolutely, the tent is wide, and so when we talk about levels of care, that may make some more sense. So when I used the term a couple of minutes ago of permanent supportive housing, that has a very specific kind of meaning in our state and beyond. That is talking about essentially, we use that language to describe typically low barrier housing. So low barrier housing might mean that a person doesn't have to be abstinent from mood altering substances in order to live there. They may have individual policies around not using on the premises and so on, but a person could be under the influence and in that kind of low barrier housing, and that wouldn't be a problem. So that's what we call typically permanent supportive housing. We're talking about, and those I would put capital letters on those because they have very specific meaning. When we're talking about housing with support, a lot of our housing provides a higher level of care and support. So we'll talk about that in a couple of minutes, actually. And so absolutely, supportive services can totally fit under the umbrella of a recovery residence. So let's talk about protective classes. So specifically now we're talking about the Fair Housing Act, and it protects people from discrimination based on all of these criteria that you're looking at there. So landlords can't discriminate, municipalities can't discriminate, and the one that, of course, interests us most in our conversation today is the one that is highlighted there, disability. So a group of folks who are living together are protected because they have the disability of addiction and they're in recovery from that disability. So let's go to the next slide. And essentially, I'll paraphrase here, but the Fair Housing Act, essentially, it prohibits a landlord or a city or a county from treating people with disabilities differently than they would treat other people. So a group of people who are living together to support one another in their recovery can't be treated differently than a family. So if they're living in a single family home, a municipality can't just like require them to say have a sprinkler system or have a whole different kind of physical infrastructure than a regular single family house might have. So they can't require them to live somewhere else or to kind of create something that would make it a huge burden for them to exist. So as long as people are in recovery and they're living together for mutual support, they're protected. And the reason why that's underlined is because if people are suffering from addiction but using, they're not protected by the act. And this becomes especially clear in a state like ours, where cannabis is legal for recreational use. If there's cannabis use in the house for anything but medical use, and even medical use is probably not going to work because it's rarely prescribed. It's almost always just suggested or recommended because it's legal. So if anyone is using it for basically recreational use in the house loses its protection under the Fair Housing Act. So that's really important to know, and that's why, at least at present, because federally, the federal law still prohibits use of cannabis, or still considers it a controlled substance, then any house that is there are homes that have what you might call green rooms or other places, and we're not saying that those folks don't have legitimately good things going on in those houses, but those houses wouldn't have the protection of the Fair Housing Act that actually really helps us be able to kind of operate as protected classes of people. So let's go to the next slide, and we'll get a little bit more into this. There is some legal backdrop that's worth talking about here. A city can restrict, and they do sometimes, the number of unrelated people living together in some cases, though some people have challenged these the ordinances and won. And of course, the biggest case went all the way up to the Supreme Court here in Washington State was Edmonds. It was Oxford House versus the city of Edmonds, and Oxford House prevailed, basically meaning that that a city would have to come up with a really compelling reason to limit the number of people living in a house, and safety is a compelling reason. So if a house is just full of bunk beds and too many people are living there, and it's an unsafe environment, the city would still have recourse and still be able to say, no, you can't operate that here because it's a fire hazard, or it's unsanitary, or whatever. So our advice really is, whenever possible, to operate underneath what city ordinances require. And there are times when we may have to make or ask for an exception, and we could do that just asking for an exception based on disability. So the legal language for that is reasonable accommodation. So some exceptions can be made for residences via those kinds of requests to like a city or municipality. So as the slide says here, landlords, municipalities, they can't discriminate against folks as long as they're in recovery and working. And so that's why that sort of abstinence-based model becomes so important for us, is that if we're abstinence-based, then we fall under the Americans with Disabilities Act and enjoy those protections. So let's talk about any questions about that. I'm certainly not a legal expert, but it's helpful to know, if you're operating a recovery residence, that you do have rights under the federal law that can't be impinged upon by city ordinances or fire codes or fire marshals. Even they have to operate underneath the federal Fair Housing Act. All right, so I'm not seeing anything. If anything comes up, let me know. Jason, were you going to throw something in there?
Yeah, Alan, you had covered a great deal of it. In my years in working in the clean and sober housing realm that I have all across Washington State, these federal housing protections that are here have really been beneficial. And as Alan touched on a little bit, the Oxford House versus the city of Edmonds, that the late Supreme Court Justice Ruth Bader Ginsburg issued her final dissent on, really set a landmark here, not only a precedence for Washington State, but all across the country. From time to time, I will have, I'll get phone calls, if you will, from overzealous code enforcement officers or a new city attorney that's out there trying to make a name for themselves, that you can't do this. You can't have a clean and sober living residence here. It's unlawful, yada yada. I've heard more stories over the last decade that I can shake a stick at, but I usually just refer them back to that case law that was set. I tell them to review that Oxford House versus City of Edmonds, and after they do, to give me a call and we can have further conversation. And fortunately for us here in Washington, that's usually the last phone call I have with them. So those federal protections are there and they're in place, and definitely a good benefit for us. Holly had posted a question on there. Harm reduction programs. Harm reduction programs here in Washington State, and just as vital, the harm reduction programs is our abstinence based models that we have here in Washington. There's definitely a place, like I said, definitely a place for the harm reduction models. I've seen individuals have a great deal of success when they started out in and with the harm reduction models. But again, is Alan touched on a little bit here at WAQRR, with the standards that we've adopted directly from NAR, which is the National Alliance of Quality Residences. All of our programs, our standards, our procedures that we've adopted are all based on an abstinence-based model.
So if you're looking for, sort of back to the legal framework, if you're looking for a really good kind of summary document, a ways to kind of understand how the Fair Housing Act interacts, I'd refer you to our website. We have a copy there of a document, a joint document issued jointly by the Department of Housing and Urban Development and the Department of Justice. Wrote a memo a number of years ago that essentially the audience for the memo is sort of local governments, and it just kind of advises them on what they can and can't do, or for our purposes, especially as it relates to people with disabilities. And there's some examples, really good examples in there around recovery housing specifically. So that's just a great document. If you are a recovery residence operator, that is a document to have on your shelf and to have available digitally. So if you need to send it to somebody in your city, and I've done that a couple times just as a friendly reminder of kind of what our category is, where we fit. And that's a really helpful document. You can find that in the resources section of WAQRR.org website. So
Alan,
let's go.
Holly had her hand up.
Yeah, sure. Go ahead, Holly.
Holly, are you with us?
And you can unmute yourself. That will help. Okay.
Yeah. So yes, thank you very much for your input on that. But where I was going with is, so what our organization does is we house people who are directly coming from Eastern or Western state, and a lot of them have had a history of drug use and for self-medication. And so when I put in there harm reduction programs, is that, I know that it's difficult in order to stay abstinent. And I mean, there could be a rule of abstinent, but what I've seen, the reality is that if people don't have an ability to, or tools to maintain abstinence, then it's difficult for them to stay on that path. And that's kind of where my thrust was going with the harm reduction. Is like, is there in these houses, yes, there's a rule of abstinence, but is there any tools for abstinence?
Yeah, so a good recovery residence is all about providing people the support that they need in order to do it. And so when we get into levels of care, we'll talk a little bit more about that. But somebody who maybe has never been in recovery before, maybe maybe has been using for 20 years or so, and this is their first dip into recovery, they're going to need a higher level of care than somebody who maybe has been abstinent for a long time, and maybe they had a slip and they, you know, they were out for a little bit, but they have some resources. They have what we call recovery capital under their belt that's going to help them actually do that job of stepping back into recovery. And we're also going to talk this afternoon, we're going to spend some time talking about return to use policies. So there's a range of things that we can do when somebody returns to use, everything from a very strict policy that says, hey, you've got 15 minutes to get your stuff out of here and leave. You can tell that I'm not a huge fan of that particular model, all the way to maybe something that feels very, very gracious, and where a person is given second, third, fourth chances, but we can still call the environment a sober housing environment, and have rules in place to talk about that, but still treat people with respect and still recognize that this is a chronic condition, not an acute one, and we need to treat people accordingly. Does that make sense, Holly, at least for now? So we'll,
yeah, and so Holly is the one who set it up for our company. This is actually LaShanda. But yes,
hi,
that
LaShanda.
does make that does make sense for me. And thank you very much for that explanation.
We're going to get more into both of those topics here in a little bit. So hopefully by the end here, you'll have a clear sense of at least where we're at in terms of helping people kind of navigate those waters. So, all right, well, let's talk about landlord rights, because the Fair Housing Act actually has something to say to us about we as landlords or housing operators are able to operate. We can definitely have something to say about how people act while they're in our homes, and people's behavior in homes can be really destructive to a program of recovery for other people, and even dangerous for people who are trying to live lives of recovery, especially with the lethality of some of the drugs that are out there now. But just real quickly, we don't have to, if regardless of a person's disability, if there's behavior that is, the word is nuisance, but I think nuisance kind of understates the kind of behavior for which we could ask somebody to leave. But if somebody is being really destructive in the environment, and has been given the appropriate number of warnings and all of that, there is still a recourse for a landlord or for us as housing operators to say, boy, this isn't going to work. And hopefully we could do that in a way that honors them and provides them another place to be. People with poor credit, I kind of laugh at this because we do have the right to turn away folks or to not let folks in our homes if they don't have good credit. But I don't know about you all, those of you who operate, if we did this, we wouldn't have many residents at all. So it's a whole other topic, but essentially there is, just like other landlords can do credit checks and so on, we certainly can do that. I don't know many operators who do, because again, I think that would be a detrimental kind of policy toward the folks, many of the folks that we work with. And people who can't pay, same thing applies here. If they don't demonstrate on their way in that they have a means for paying for their rent or program fee, then we as operators don't have to let somebody in just because they qualify under the disability provision. So just because somebody is in recovery doesn't mean that they're entitled to housing. That said, because so often addiction is so destructive to a person's financial life, we really try to do everything we can to work with folks. The other thing I'll say too, on behalf of WAQRR, is that WAQRR has succeeded in securing a lot of funding through the legislature for people in recovery who are looking for housing. And so there are state programs, the HARPS program, the HEN program, which is essentially federal. But the HARPS program has been expanded significantly in the last couple of years, thanks to our legislative efforts. And we also have some kind of emergency funding that accredited operators that are accredited by WAQRR have access to some funds to help residents in their first 3 months living with them And so we are really trying to do everything we can to make it so that we don't have to say no to people because of financing. And so if you have any questions about that, I'd like to kind of hold off on that until the end of the day. We can talk specifically about the kind of funding sources that are available, but just wanted to let you know that, yep, we can turn people away for financial reasons. I think that's probably bad policy if we're trying to serve people. But just so you know, it's doable. All right, let's go to the next slide. Yeah, I think it's probably just helpful to say that the Fair Housing Act protects people. It also protects us, and it instructs us on some things that we need to know about. So this slide, I wanted to put it in here. We're going to talk a little bit more this afternoon about return to use policies. This is the only thing in Washington state law that talks about if there's a clean and sober environment. Let's go back to that one if we can, Jason. If there's a clean and sober environment that a house is trying to maintain and a person returns to use, this particular law applies only to a very narrow group of houses in Washington state. They're actually called recovery houses, and they have clinical services in them, and they look they're an awful lot like inpatient treatment. They have clinical services, they dispense medication, their facilities have to meet a high standard. And so this applies to them. There's this 3-day rule that says that you've got to give a person a chance to kind of to change their behavior. They have 3 days to sort of get that together. And then if nothing changes, then a person can, or an operator can ask a person to leave. The reason why we're putting it here, even though it doesn't apply to most of us, is that because this is in the law, it is likely that a judge would look at this and say, well, this is the only standard that's legally around. So if we ever got challenged on asking someone to leave a house because of returning to use, this might be, if we got legally challenged, this might be where a judge might go. And so we just want to make people aware of this. So it's not a bad idea to have policies in place that might look something like this. Yours might look different, and you certainly have the right to do something different, but there's a pretty big gray area here in terms of what abstinence means and what our response is when somebody isn't living an abstinent lifestyle. So just showing you this, and I put it kind of in the legal section because I wanted you to just know that, yeah, there's a little bit of legality here around what we're responsible to do. If I were to kind of read the spirit of this is that people have a chronic disorder that has relapse as a part of the pattern, and so our policy should reflect somewhere that's the case, and that a person's housing shouldn't necessarily be in jeopardy immediately upon a use. Maybe there are other things that we can do, especially aside from evicting somebody on a permanent basis. Maybe there are other things. So we're going to talk about that later this afternoon, but wanted to just sort of, this issue comes up a lot when people are talking about recovery residences and the difference between a recovery residence and a permanent supportive housing, kind of a low barrier environment. And we just want to say we in our field absolutely have the ability to be humane and to work with people and to help them in their time of need when they might need community the most. All right, I'm done preaching about that. Let's go to the next section, which I promised before. It's called levels of care. And so 13, 14 years ago, several state organizations got together and they were organizations like ours here at WAQRR. Let's go back to that slide because I don't want to get into the reading quite yet. I want to sort of set it up. Thanks a lot. They got together and organizations like WAQRR, who are kind of statewide organizations of recovery residences, and said, hey, we should have some sort of standard in place about what it means to do what's like a minimum standard that people need to meet in order to do this work. And as they were doing that, they tried to figure out, well, we want there to be space in our standards for different kinds of recovery housing. And there are some kinds that are real basic, that don't offer a whole lot of support and other kinds that offer a ton of support. We'd like to make room under the umbrella for all of them. And so how do we do that? Well, so what they came up with is levels of care. And by the way, this is under review right now and is probably going to change pretty significantly before long. Recovery housing is now going to be underneath the ASAM standards. And so if you're in the clinical world, you know something about what ASAM levels mean. But right now I'm going to familiarize you with NAR levels of care. And then, and again, I think this will probably shift to align with ASAM a lot better than it does right now. So if ASAM doesn't mean anything to you, don't worry about that. But down the road, we'll all get a little bit more familiar with what that means. But anyway, let's go to the next slide, and I'll kind of walk you through. Oops, I think we went the wrong direction there. Here we go. There we go. So they came up with 4 levels of care. I'm going to walk you through them real quickly in a couple different categories. But the first one, and by the way, none is better than the other. None is, we don't need one more than we need the others. We need all of them, and they all exist, and they're all really important depending on what people need. So the first level of care is peer-led, peer-elected officers in a house, and this might be familiar to a lot of you in Washington and beyond, is Oxford House. Oxford House is the best example we have of level 1 housing organizations where on the ground, the peers are deciding who gets into the house, when someone has to leave, how they're going to do the finances, all of that kind of stuff. The Oxford Charter has something to say about how those things work, but basically that happens all at the peer level. There's no one from outside of the house, aside from Oxford, that is telling them how to do things. There's no boss. A lot of the decisions are made right there in the home. The second, I think you can click through these, Jason, just to kind of a highlight thing. Go ahead and click to the next one. There we go. So the next one we call sober living homes. And these are level 2. So in a sober living home, typically wouldn't have a lot of programs. They would have maybe there's someone who has property and they want to use it for good, and so they set up the property with maybe a house manager, and that house manager enforces the rules, maybe with the help of the owner, kind of decides who gets to be in the house and when someone needs to be asked to leave, and those kinds of really heavier decisions. They're probably closer to being self-supporting, meaning that the rents that people pay pretty much pay for the housing. And so, but there's usually some extra level of support. There might be some requirements around going to meetings, around some structured kind of things. And then the level 3 houses then would have things like some life skills stuff. They would be we would call in Washington, this has a very specific definition, the recovery house that I talked about, but in the rest of the country, level 3 means that that you can point to a program. So there's a recovery program within the house, usually staffed, not overnight, typically, depending on the level. Some of the higher level of care might have staff. They might even have clinical components in them. But the thing that distinguishes them is sort of life skills and really just a lot of support for people who might be coming out of institutions like incarceration or inpatient treatment settings and so on. And then level 4 would be what we call inpatient treatment. So where there's definitely clinical components, there's medication is actually dispensed by the facility. There's not a lot of freedom for people to kind of do what they want, leave during the day, that kind of stuff. Most facilities, they're pretty well on the facility 24/7, and it's generally a pretty short stay. Right, so that's kind of the way they're staffed. They're staffed with licensed folks, licensed professionals, and as well as others. But they're definitely kind of the highest level of care. All right, so let's go to the next slide. So staffing was kind of one dimension. The next slide is going to talk about the next dimension of care. And it's just services. So all of the levels of care provide housing. That makes sense. The next one, social model. So that just means that instead of, or maybe alongside a clinical model, there are components like peer support. And so even if we're talking about inpatient care facility, there would be some sort of resident council, there would be a buddy system, there would be people who are helping people who haven't been there as long. So definitely groups, a lot of groups. So even though they might have a clinical kind of feel, they really are depending on peers to do some of the connection. All right. So that's social model. The next one, as you can tell, only applies to the higher levels of care, but structured support. So this is what we were talking about earlier. Where absolutely we want this could be everything from helping people manage conflict to budgets to other kinds of life skills kind of stuff. I think there's another category called life skills here, but there might be some structure around how many meetings a person needs to go to a week, and there might even be in-house opportunities to do that and kind of building recovery capital that way. The next one is life skills, and again, that generally some level 2 homes would have life skills as well, but the demarcation here is that you'd be getting into level 3 when you're actually helping people do life, and hopefully that's happening at all levels, but these would be specific kind of structured activities. And then the next one is clinical, which again in Washington you could see in level 3 houses as well, but level 3 and 4 houses would have clinical services. And then there's one more add-on here, and that is that maybe an outpatient care facility would they'd have outpatient services, but they would also add on a housing component because they realized that, wow, if we had a level 2 house aside, that our folks, our patients can be a part of, that will help their recovery outcomes. It just makes it really improves things. So they might add on some recovery housing to their portfolio, which can be super helpful to them in terms of seeing people really do better in their services. All right. So if you could choose, right, if we had enough spaces across the system in all 4 levels of care, how might you decide? This is a really important question. And if you're an operator, I want to put this question to you to say, you need to think about what level of care you're operating at, and especially in terms of who you want to invite into your house. So, so if you have someone who has who really needs a higher level of care and you don't have that, you can really be a part of that person's kind of failure scenario if there's not enough support for them living in your home. You could also provide really high level of care for somebody who doesn't need it, and that person could be taking up a spot in your home where they could succeed very well in an Oxford house or in maybe a level 2 kind of a sober home, and they don't need that level of care. So really important to sort of think through in your application process who you're letting in. So this next slide then we'll walk through a couple of things here, both for people who are referring people to recovery housing as well as those of us who are receiving people in terms of how we want to make decisions about who should go where. So the first thing, I've talked about this term a little bit, recovery capital, so important. Well, these are the internal and external resources that a person has to actually succeed in long-term recovery. Do they have a doctor? Do they have a counselor? Do they know where the recovery meetings are in town? Do they know, do they have a group of people who help them with their financial issues? Do they have someone who they go to help them when it's time to go to court? So all that and a lot more fit under recovery capital. So the more recovery capital a person has, the more likely they're going to be able to succeed, like in an Oxford house. The less they have, if this is their first run at this, they're going to need to be in a level 3, certainly a level 4 place to maybe start, but a level 3 for sure. And start there and gain some of that capital. The severity of their disorder and the complexity of it. And I don't need to tell you all that there's a high correlation between person's trauma history and other kind of pieces of their story and their propensity towards addiction. If they have a really complex story, And again, they don't have a lot of recovery capital. We really are going to want them in a higher level of care, especially for a while until they kind of work through that, and the severity of what's going on with them can be kind of worked out until they're actually got a better control, and they're not less likely to return to use and to those destructive patterns. So the next one, stages of development. So this is where people, some people socially need to develop more, and in those higher levels of care can do that before they move into other levels of care. That it's going to be expected that they have some of those kinds of skills. Some folks, just because of maybe developmental disabilities, may struggle and may not be able to move into a lower level of care, maybe ever, because of the needs they have in other kinds of areas of their lives. So always paying attention. In our program, we have a recovery program that requires some writing and some reading and some ability to interact with a coach, and really work on their recovery. So there's someone, if they're really developmentally disabled, we may not be the best spot for them. They may need a higher level of care that's actually helping them really work on the basics of doing life before they would come to someplace like us. All right, next. Person-driven choice. This is a value at all levels of care. So even if someone has chosen to be and has been recommended to be in a really high level of care for a time, hopefully they're there because they've chosen it, they know that they need it, and they're going to comply with what's asked of them there, because they're choosing to do it. So we don't, we would never take someone who's kind of court assigned to our program, who just doesn't want to be there and is angry about being there. That's not honoring their choices. And so we always want to work with folks who want to be where they're placed. Okay, finally, on this one is that the reality is that there's just not enough of housing in any of these levels. So when Oxford House International wants to open a new Oxford House in a city, we are overjoyed because they need it. When we have a new inpatient care facility that opens up, we need those beds. And we definitely need everywhere in between, which most WAQRR houses kind of straddle that level 2, level 3. We call them all level 2 in Washington because level 3 has a very specific meaning, but in the national model, level 2s and level 3s kind of fit nicely in the kind of the WAQRR umbrella of the houses that we accredit. But want you to kind of think about the whole level of care, especially when you're thinking about where someone who you're working with might need to go, or when you have an applicant who is headed to or wants to apply to your housing. They need to know what you do and don't provide in the kind of in the realm of level of care. All right, next, just real quick, we'll go through this one. Just length of stay varies, of course. So the higher the level of care, typically the shorter the stay, because the need and also the expense. Higher level of care is really expensive. Next, accountability and supervision, of course, is higher in the higher levels of care. And next, a person has a lot more ability to personalize their program at the lower level of care. In other words, they don't need someone kind of structuring their day very much. They're probably working. If they're in Oxford, they're working because they're paying their rent, or they're going to school. They're doing something to build their lives. They have a lot of autonomy over those things. And that, the closer you get to inpatient treatment and structured services, the less personalization that happens. But again, the person's choosing that for where they are in their recovery. Next, is just a deeper connection to community as a value across all levels of care. The opposite of addiction is indeed connection. And so that's the thing that helps people recover. And so anything we can do, if you're an operator, you should be able to articulate how are you connecting people to other people in recovery and other people who are going to help them build their recovery capital that we talked about. It's essential. We're not running, I was advising one of our tribes who was wanting to build some recovery housing, I saw a drawing of what they had planned, and there were a bunch of single rooms that were huge, but they were single rooms and they had TVs in them and they looked like really nice hotel rooms, and there was hardly any common space at all for people to meet and connect with each other. And I just said, wow, this is terrible. And thankfully, as they were kind of came up with future plans, they worked on kind of changing that around a little bit to say, you know, maybe people need to live with roommates, not because we're trying to save a bunch of money, but because it's really helpful to people to learn how to develop those skills. And certainly they need a place to run into each other and to eat together and to do those kind of community things that are so essential. All right, so let's keep going. And so I'm going to turn it over. I think Karen has this section. She's going to talk about the standards that I referenced earlier that have to do with our accreditation process. So I'll turn it over to you, Karen, and thanks much.
Jason, did you have something on this slide you were going to say?
I can gladly I'll gladly go over the quality standards this morning. As I alluded to a little bit earlier in one of Alan's previous slides, WAQRR is under what is called the NAR umbrella, the National Alliance of Recovery Residences. And 95% of our quality standards that we utilize here in Washington State, we've adopted directly from NAR. I'm going to spend a little bit of time this morning going over our standard core principles and such. And again, guys, if you have any questions or it sparks anything, don't hesitate to use the raise hand feature or put anything into the chat, and we'll do our very best to be able to expand on some of these topics a little bit further. Our core standards and principles. Operate with integrity, mission, legality, ethics, and good business practices. So Sarah will touch on a little bit later on today in what our accreditation process looks like. But when an individual is going through the accreditation process, all of these standard core principles here are definitely things that we look at very thoroughly when we're reviewing an individual's documents, their rules, their policies and procedures. We want to be sure that all of our operators across Washington State have a mission statement in place. Legality, we want to be sure that they're at the very least registered with the Washington State Secretary of State. We've all heard the horror stories about recovery residences that are out there. I believe it was maybe somebody from Snohomish County who was joining us today who had some experiences with some, we'll say, less than favorable recovery residences out there. The sad truth of the matter is that there's some individuals out there that truly take advantage of individuals in recovery. They think that recovery housing is no more than opening up a house and shoving bunk beds into a bedroom and hanging a shingle out front, and all of a sudden that they have a recovery residence. The whole law that was enacted that went into effect on January 1st of this year was kind of put in place to hopefully put those individual houses that are out there out of business. The Washington State, the Healthcare Authority, the Department of Health, some of our legislators all started to receive some emails and some phone calls, and those emails and phone calls started to become more and more started coming in with more frequency about the unethical complaints of individuals that were out there, and just overall treating the individuals that were in recovery, some of our most vulnerable citizens, if you will, that they were just taking advantage of them. I guess just to put a little, for those of you that aren't aware, the law that I was speaking of that went into effect on January 1st of this year makes it unlawful for any Department of Health licensed, any Department of Health licensed, if they hold a Department of Health licensure, it makes it unlawful for them to make a referral to a recovery residence if that recovery residence isn't listed on the healthcare authority's website. All of the Oxford houses that are out there across Washington state were grandfathered in, as Oxford House has a time-tested model that's been around since the 70s. All of those homes were grandfathered in to the list. Any other recovery home out there must go through the accreditation process, have all of their rules, their policies and procedures, and their actual physical structure thoroughly examined. And WAQRR is that entity here in Washington state that handles that for the healthcare authority. Again, we look for a very sound mission statement. We want to be sure that all of the legal documents are in place, that each recovery residence has at least $1 million in general liability coverage for their business, and their record in their recorded with the Washington State Secretary of State. We also look over all of those documents to be sure that they're operating in an ethical manner. We want to be sure that the ethics that they employ within their program is also very transparent to all of the residents that live there. We also want to be sure that they have good, sound business practices in place, not only for the residents, but also for the employees that they employ, for the volunteers that they have coming in working for their residents, and for all involved in that residence as a whole. We want to be sure that they uphold residents' rights. Rights and rules are communicated. We want to be sure, again, that there is full transparency for the individuals that are coming in and moving into the recovery residence, what those rights and rules are, exactly what can the person expect when the person moves into the home. What's expected of them during the day-to-day. Heaven forbid somebody relapses and that has to be asked to leave the house, exactly what that looks like, when they might be able to return to the house, what the rules are for just for simple stuff, the day-to-day operations, what they can expect from the managers and the individuals that they oversee the house. Creating a culture of empowerment. Residents are involved in governance. We want to be sure that all of the residents at the house, that there's actually house meetings going on, that individual residents that are living in the house have a right in a place that they can sit down and air their thoughts, their concerns, and at the same time be able to congratulate individuals. We want to be sure that everybody in the house has an equal voice and that they have time to be able to sit down and communicate that. Develop staff ability to apply the social model, staff model, and teach recovery behaviors. We want to be sure that the individuals in that house are not only talking the talk, but walking the walk, if you will, that they're encouraging the individuals who live in the house as they continue down their recovery journey. If stuff comes up in the house that the individuals in the house may be struggling with, that they need help with, we want to be sure that that help is there and afforded to them. And sometimes that isn't directly by the staff in the house. It might be through community partners or other agencies that they've partnered with across the state. But again, we want each home and each program to be able to create a culture of empowerment. Develop staff ability to apply this, provide a home-like environment. We want to be sure that all of these are actually set up like recovery residences, very similar to the homes that you and I live in today. We don't want them to be institutional settings. We want them to be very, very home-like, in a home-like environment, and provide a safe and healthy environment. We want all of the environments to be healthy. We want them to be clean. We want them to be a place that affords the individuals that live there the opportunity to grow. Here at WAQRR, during part of our accreditation process, we actually come into the home. We thoroughly inspect the home for all of the safety standards, meaning that there's not there's not too many beds in one room, that there's enough refrigerators, that all of the appliances are in working order, that there's enough bathrooms, that all of the exit doors that lead to the outside are plainly marked as such, that all of the bedrooms have egress windows. We take the safety of the residents and all of the providers very serious, and want to be sure that everybody's afforded a safe and healthy environment. We want to be sure that they facilitate active recovery and community involvement. I don't want to get too far in the weeds with the accreditation process, as Sarah's going to touch on that a little bit later on, but part of that, we do a very thorough interview with them. We want to be sure that there are some recovery standards and activities that take place, whether that is through unity events. It might be partnering with different agencies in the community to be able to go to NA, AA, softball, summertime events, celebrate recovery, whatever that may be. We just want to be sure that individuals are afforded the opportunity to take place in those recovery community events, and promote access to community support, model pro-social behaviors and relationship development skills. Again, these pro-social behaviors and relationship development skills, sometimes that is done directly in the house, either through staffing. Sometimes that is done with partnering with outside community agencies, and sometimes is done by a combination of both of those. We just want to be sure, again, that the pro-social models and behaviors and the relationship development skills are somehow afforded to the individuals that live there in the recovery residence. Cultivate resident sense of belonging and responsibility to the community. Be a good neighbor. Some of the rules, policies, and procedures that we ask what does your good neighbor policy look like? What is explained when the individuals move into the house? We want to be sure that the houses have stuff set up, that there's a quiet time, whatever that may be. That varies from residence to residence, just so individuals aren't out talking loudly at 10:30, 11 o'clock at night when the neighbor's house and windows are right there, or that they definitely have a place where they can where the residents can gather to smoke. That parking is always a big thing when it comes to recovery residences. We want to be sure that it's set up so that there's not one parking spot in front of your house and the 3 or 4 that might be available in front of your neighbor's house are all taken up by the individuals in your recovery residence. Being a good neighbor is very, very important, and I'll touch a little further on that after our lunch break when we chat about NIMBYism. And policies regarding noise, being a good neighbor, policies regarding noise, smoking in vehicles. Again, it's just very, very, very important. A lot of individuals, when we first move in and set up recovery housing, just the stigma around recovery housing as a whole. A lot of times it can be a battle, and getting that across to the neighbors that we can be good citizens, and that's why we put these houses in good neighborhoods. But we definitely review that during our document review time to be sure that all of the residences do have a good neighbor policy in place. Guys, usually this is where we pause for lunch, but I think we're gonna push forward until about 11:30. We'll go for about another 15-20 minutes, and then we'll pause for lunch from 11:30 to 12, and then be able to give people back some of their day this afternoon, if that's okay. Does anybody have any questions at all around our standard core principles? Did it spark anything in anyone that they need some further clarification on? Okay. we're going to have our some open discussion about around current issues. And to start off, I'm going to talk a little bit about NIMBYism. For those of you who aren't familiar with the term, NIMBYism stands for not in my backyard. There's a lot of stigma around recovery and recovery capital as a whole. The basis for a lot of this, as you're aware, the news loves to sensationalize, if you will, the bad that happens when individuals return to use. Individuals get locked up in jail and it was driven by drugs, or individuals got in a high-speed chase and there were drugs, there were alcohol involved. In people's mind, the sad thing just automatically goes to, okay, well, individuals that there's drugs and alcohol, there was drugs and alcohol involved in the crime, so automatically makes for bad people in bad circumstances. Every now and then, the news will put out a feel-good story about individuals that recovery is possible, that individuals can recover, but the sad side of things is they love to sensationalize usually the negative connotations of recovery rather than the positive side of things. It's always my suggestion, and I've opened up a great deal of recovery residences over the years, and it is always my suggestion, though the neighborhoods can't stop you. You do have a legal right to be there, but it's always good to get out ahead of things if you can. If you're a new recovery residence operator, there's absolutely nothing wrong with reaching out to individuals that are in our WAQRR network to ask some individuals to get together with you. I always suggest hosting an open house at the recovery residence that you're getting ready to open, just to break down the fears, dispel some of that negative and the negative thoughts that the neighbors out there that the neighbors might have. I'm going to read some of the, I'm going to read a couple best practices for housing advocates to overcome NIMBYism. The best defense to NIMBYism is a good offense, and a good offense means to know your legal rights. When discrimination and against an affordable housing development is really discrimination against a race, color, national origin, religious, disability, sex, or familiar status, it violates the Federal Fair Housing Act. State and local fair housing protections may include additional characteristics protected from discrimination. Litigation is usually not a meaningful remedy because housing funding cycles are on a tight frame, and the media can be an important ally throughout the process to develop approval. Whenever you foresee a potential NIMBY problem, it is best to contact the media first so that they understand your development plans and its beneficial public purpose. In this way, the neighborhood opposition will have to justify to the media why it makes sense to stop development that the media already considers an asset for the community. Again, the best defense is a good offense. And again, that's why I was speaking on when you're getting ready to open up a home, it's always best to go over, host an open house, be able to sit down and answer all of the neighbors' questions and everything that may come up. And again, that can be something that's very scary, especially if you're just opening up your first recovery residence. Again, we have a great deal of providers here within our WAQRR network. Definitely reach out to us, and we will gladly assist you through that process if needed. Address all legitimate opposition. The key to overcoming NIMBYism is to address all legitimate concerns expressed by the opposition usually being the neighbors. Those concerns may be, for example, traffic, available infrastructure, or project design, issues that may lead you to adjust your proposed development. The developers should come prepared with professional studies, infrastructure impact reports, and other important planning documents so that what may be legitimate concerns can be addressed. If you address all legitimate concerns and the opposition persists, you are now in the inevitable position of being able to state with certainty that the opposition is illegitimate. It is, therefore, opposition that would be inappropriate, arbitrary, capricious, and unlawful for the local government to consider in making its land use decision. In other words, you would win. I've had to sit in front of several city councils in my years doing this. The city of Yakima, I don't know why. I've been in front of them a few different times over the years with NIMBYism stuff. New recovery residents will come in and open, and individuals will call the city and raise a stink, if you will, that recovery residents operators are there. But at the end of the day, if an individual has some good knowledge, some good background, NIMBYism most of the time can be overcome. Alan and I worked with a city up in northern Washington. To be honest, guys, and NIMBYism was so strong there. I'd never seen nothing like it. They just kept fueling the fire, perpetuating the negativity. This city whom I won't name today, they had a tremendous problem up there with homelessness. A lot of drug activity, like we see all across the state, and for whatever reason, the city really dug their feet in up there. Alan actually had the opportunity to go up there, and he was able to calm some of their needs, but I was literally receiving sometimes 5 and 6 emails a day from individuals up there that just didn't want to have anything to do with recovery housing. The biggest reason that it got to the point that it did with that particular city is a recovery residence operator just wasn't really communicating, if you will, with the neighbors. The neighbors were very, very hard on the couple to start with about their needs to want to open up a recovery residence, and the operator just really shut down. Guys, that's one of the worst things that you can do. If individuals come at you with concerns, a lot of time those concerns again are just driven by fear, and that fear is fear of the unknown. What's going to happen in my neighborhood. Home prices are actually going to go down. I've heard the amount of theft, the amount of crime is all going to go up, and you just have to be prepared to be able to sit down with the individuals and address all of that stuff when it comes up. Again, here in Washington State, as Alan touched on, we're blessed to have a lot of legal backing here that allows those recovery residences to be here. Again, not only on a state level, but also on a county level. The Oxford House versus the City of Edmonds that I keep referring to, if you have not had time to review that and you're looking to open up a recovery residence, I always I always encourage individuals to take a minute and just Google that. It's some very good reading, and it gives you a good basis. Basically what Oxford House, what that whole suit was based on. It was based on a few different things, but one of the major things was having unrelated individuals being able to live together under the same roof. Individuals that live in a recovery residence, statutorily by the Federal Fair Housing Act, those individuals living under that roof are classified as being disabled. So there's a whole lot of protections there. I've had to go to court a couple times for, like I said, for various different cases, and it's just it just simply comes down at the end of the day. NIMBYism and being able to overcome that is to being able to provide education, if you will, to them to be able to overcome that. Part of that can be educating elected officials. There's absolutely nothing wrong after you get in this business and you're doing it for a while to call out and set up meetings with your commissioners in your local area, to go meet with your local officials, to go meet with your fire chief. Usually all your police chiefs and sheriffs in your local community will have a once a month or once a quarter meeting. Try and figure out where that meeting is going to be, and see if you can get on their list to go in. Present who you are, what your program is, that when thoughts and concerns come up, that if individuals have questions with our community partners, including the law enforcement agencies, the sheriff's department, that they can reach out to you. It's equally important, I guess, to garner allies that are out there, individuals that provide affordable housing, so your individuals have somewhere to go and transition into when they're getting ready to graduate from your program.
Jason, we have a quick question here from Barry.
Yeah, sure. Go ahead, Barry.
Okay. So recently, there were several deaths of homeless folks in LA and Las Vegas. It's dangerous to be homeless and struggling with addiction. Our board has directed that our recovery residents be specifically designed for homeless individuals. Do you have experience with recovery residences for homeless folks? And are there differences for this population?
Barry, I would say that at the end of the day, humans are humans. As Alan touched on a little bit, each class of individuals that we choose to work with, some will require a higher level of care, than some individuals will. If you're going to, if you're going to have a WAQRR accredited and a WAQRR based housing program, definitely you want to be sure that the abstinence base piece is there and in place. Usually recovery residence operators will have for lack of better words, a braided approach to the individuals that they will accept. A lot of recovery residence operators will definitely work with the individuals that have been homeless for a great period of time. They'll also work with individuals coming from inpatient treatment facilities, from jails, from prisons, and about everywhere else that I can imagine. Again, this is my own personal experience in working in recovery and recovery housing. It's better to have a bit of a braided approach, if you will, to the individuals that you accept. A lot of our and I realize, Barry, up there in your area that you guys don't necessarily have a mission not a mission for your program, but like a Union Gospel mission or a Salvation Army mission or something like that. Usually those are usually the organizations, if you will, that work strictly with the homeless population. But again, Barry, if that's your target audience that you're going for, just the individuals that are homeless there in your community, absolutely, it can be done. I would suggest perhaps maybe reaching out to the Union Gospel Mission, maybe reaching out to the Salvation Army, something like that, because each specific subset, if you will, of individuals that you work with, especially the individuals that may have been facing years and years of chronic homelessness, some of their needs may be a little bit different than the individuals that are coming straight to you from an inpatient facility or coming to you from somewhere else where they may have been otherwise housed, including jails and prisons and such like that. I would just encourage you to reach out to those organizations who work with those individuals day in and day out to be sure all of your I's are dotted and your T's are crossed, especially when it comes to the resources for those individuals that are first moving in. I would assume a lot of times when those individuals are transitioning into the house, perhaps they might not have any clothing whatsoever. They're probably not going to have food. A lot of them might not even have the ability to get food. They might not have a food stamp card. So a lot of just the very, very basic necessities and needs. I would just be sure that you have all of those resources there and firmly in place to be able to immediately be able to take care of those needs when individuals are moving in.
Hey, Jason, can I throw one thing in there?
Absolutely.
So I think I'd like to really make sure and go back to the fact that a recovery residence, the mission, where, Jason talked about that as one of the standards, that the mission is to serve people who are struggling with substance use disorder. And in the world today, it's really difficult because there is so much need. The homelessness is so great that to make sure that as a recovery residence, the people also are struggling with substance use disorder. It's not just somebody who's homeless and needs a home. I know for us personally, we've had applications where it's people who are struggling with homelessness and they maybe have used drugs, but they don't really struggle with substance use disorder. So just know that to be a WAQRR home, that still has to be the mission of what you do. And it's difficult in today because there's so much need and it's really hard to turn somebody away if they don't fit with that. I just wanted to throw that in. I don't know if you have anything else with that, Jason.
No, that's great, Karen. Barry, did that answer? I want to just be sure that I 100% answer your question there. If there's anything further I can touch on for you.
No, Jason and Karen, thanks for your responses. They're both really helpful. We have some housing that is specifically for homeless folks, but we also our board has directed that they want to create this specific location as addressing the needs of homeless folks who are experiencing addiction and in recovery. So we want to create a path out of their present situation. So that's really helpful. Thank you.
No, absolutely. And thank you for the question, Barry. Does anybody else have any other questions related to NIMBYism and how one might work to combat that, or any further explanation I can provide on any of the topics that I've covered? All righty. With that being said, we're at 11:30. We will take about a 30-minute lunch break, and we will return at noon. And Alan will rejoin us, and we'll talk a little bit on co-occurring challenges. Dual diagnosis, or individuals, in other words, individuals that are suffering from mental health and SUD. I will see all of you again here at 12 o'clock, and hope you all enjoy your lunch.
really hoping that you all will have a sense of what you're looking for in terms of the quality of the places you're referring folks to. So it really does matter. So important that there's some kind of basic standard. And we, in WAQRR, we're about accountability, but also, of course, support. And so we support our operators in kind of meeting the standard, and with the hopes that, when I want to refer somebody somewhere, I don't have to know tons about an organization if I know that they're accredited, if I know that they've been through what we had to go through in order to earn the accreditation of the organization. I know that, okay, well, this is an organization that someone has walked through their facilities, made sure that they're safe and that they're welcoming, and that they are recovery environments. They have their documents. Everyone's been through those, and they know that there are policies in place that protect residents from being mistreated. There are policies in place that are recovery focused. There's a peer environment of support in those places. So anyway, all that to say, all those standards are about is trying to give all of us a sense of confidence in each other and in other operators around the state, so that when we do that referral, either because maybe we don't have the right level of care for somebody, or maybe we don't they need to be in a place that is different from where we are. And so I need a place in Walla Walla for a woman who is moving there and needs connection. Well, I know someone there, and I know that they're accredited and that they meet the standard. And so it's really vitally important that we have some sense that there's a bar and people who live with us are at their kind of most vulnerable place. And so one thing that kind of got us to start WAQRR 5-6 years ago now was seeing that kind of in the name of recovery housing, there were organizations out there that were doing harm to people. Some of those were, just because they didn't care. Most of them were because they just didn't know enough about how to do it right. And so our goal is to help people know how to do it right. And so that's what today is about, and that's what really we want to be about as an organization over time. And so that's why we're doing what we do. Jason, should we dive into this next section that I'm done preaching
Alan,
about that?
Let me say something really quick to that, Alan, because I think this is important, is that accreditation occurs every year. So I think just so people know, because I think maybe somebody might think that people could kind of slide and maybe not be keeping those up. But as WAQRR, we make sure annually that people are meeting that high standard. And I think that's really important.
Yeah, and we reserve the right to just pop in and see how something's going, and to just pop into someone's place and just see if it looks in the middle of the year like it does during accreditation time. And every once in a while we've done that. And we have a really good grievance process. So if somebody has a concern about a house that's accredited, there's a process that we would go through to help resolve that issue. If it's been dealt with at kind of the local level, then we can sort of step in and be a part of either improving a system or something that needs to improve, or helping a resident communicate with the operator in a way that would resolve the situation. So anyway, so that's just some of what we're about. But a lot of today is about just getting you thinking about, if you're a referral source, what it is that you're looking for, and that you're looking for something that's quality and that meets certain level of care kind of standard based on what we talked about this morning. And then if you're an operator, kind of getting your mind around, what does it take to provide something that really adds value to someone's recovery story and to the capital that they're building. So
yeah, and one further thing I'll touch on just a little bit is I had received a text earlier about where can we find exactly the list of the accredited recovery residences in Washington State, and both of those are listed on two places. One on our WAQRR website, and also a complete list of all of the accredited recovery residences, as well as all of the Oxford houses, can be found on the Healthcare Authority's website as well. If one just Googles Healthcare Authority recovery residences directory, there is a list of all of them on there. And with that, we'll go ahead and turn it back over to Alan. Alan's going to touch a little bit this afternoon on co-occurring challenges and how those can apply directly to the recovery residences.
So this next section, we're going to talk about 3 or 4 different kind of current topics, things that are worth spending a few minutes on because they come up for us in our work. And some of them have some sort of controversy to them, and so they're different perspectives, different ways of looking at things. And so we're trying to be relevant, and if there are questions that are on your mind, that's great. Co-occurring challenges, this really isn't anything that's particularly controversial, but it's real, and it relates directly to the levels of care that we talked about earlier today. And that is that when we're accepting folks into our homes who, kind of by definition, we know that they have some challenges that are addiction related. But if you've worked in the field, you know that I would say that the majority, if not the vast majority, of the residents that we work with have another challenge or two in the mix. And whether that's something that's undiagnosed as a mental health challenge, or something that has developed because of their using, or something that that they were self-medicating with their using. So there's kind of chickens and eggs in all of that. But we know that again, I'd say the majority of the folks that we work with have something else going on, and so it's really worth paying attention to that up front when you're asking yourself, do we have the level of support here that somebody needs? And again, if you've been doing this a while, you'll know that sometimes when we work through the substance issue and get people in a place of sobriety, that some of the mental health challenge starts to kind of de-escalate. It starts to resolve itself, or at least they're able to focus on the mental health piece. Maybe for the first time be able to get on some medicated treatment that really starts to address that issue. So instead of self-medicating, they're doing the medication underneath the care of a doctor and or prescriber who's really in touch with them about what's going on. We've worked with folks who have who've been diagnosed. It works both ways. We've worked with folks who have been diagnosed with bipolar disorder, for instance, which is a pretty common diagnosis for somebody who's actively using, and for whatever reason, a doctor will sort of put that diagnosis on somebody because somebody who is using has, depending on what they're using, but can have major ups and major downs. And that looks a bit like bipolar disorder. Well, you get somebody into sobriety and into recovery, working on themselves, and those are 2 different things, by the way. But that's a different talk. But working on themselves in recovery, and those behaviors start to kind of level out because the chemicals aren't kind of messing with their natural processes anymore. And then on the other hand, we have folks who when the sort of self-medication stops, then the underlying disability becomes just more and more clear, and so that docs can really and other folks, counselors and others, can really help them zero in on what needs to happen next. And so it's a real gift when someone can get to that place of trying to sort of sort out the substance use, that kind of the illicit substance use from the mental health challenge. And they can really start to work on one. It's almost in so many ways, when somebody has an underlying mental health issue, it's almost not a fair fight trying to do recovery, because there's this other thing that's always present, that's kind of driving, that's kind of underneath. And so what an opportunity that people have who can sort of separate those out, live in a safe, supportive environment with people who can give them feedback on how they're doing, how they're acting. That's, of course, having built some trust with people in the community, which might be the first time ever that someone's actually done that. But in a trusting environment with people who will give people good feedback, can be a game changer, because then they can really start to pay attention to what's going on. Another definition of recovery that we really like is learning to trust again. And when you're in a trusting environment, you can really start to pay attention to some things that really on the street or in toxic relationships or in really unsafe environments are impossible to work on. And so our homes can provide excellent environments for people to actually start working on this stuff. And so our role then as operators is to be really attuned to kind of, if we can, kind of what people bring to the table when they move in. Some of that stuff, they've maybe never been diagnosed and it's just going on. And this may be the first time, especially if you're in a staffed environment where staff can just start be observing, wow, what's going on with this person? Boy, it looks like there's something else going on besides withdrawal or besides just straight up just recovery or post-acute withdrawal syndrome, we call pause. Those kinds of things that can happen as people are kind of getting into recovery. So when we start to see those other things, then we start to connect. We can start to connect people with a broader network of help, and hoping that they will accept that invitation to dive deeper into, wow, what would you be willing to work on this? Have you ever noticed these patterns before and these patterns of behavior, and where do you think they come from? And then we're able to really help people get to the help that they need. And then the house can be a great feedback environment for them to, any of you who have been on mental health medications or walked with people who are, that it doesn't just, you don't start taking the pill one day and then the next day everything is great. That it's almost always a process. So we can offer people the gift of the right environment for them to be in while they're figuring out what the right dosage needs to be with their provider and kind of working through all of that. So the other thing I'll say kind of relates to one of our future topics, which is kind of, has to do with when someone needs to leave the house. And there are some mental health conditions that are so extreme. And if you've been through one of these, it's a really hard situation to be in. But the goal is always, if we can't provide the level of care that somebody needs, helping them find the environment that can. And sometimes the crisis that presents itself when they're in the middle of, excuse me, when they're in the middle of the situation, whatever this crisis that arises, sometimes that makes it really impossible to have kind of a reasoned conversation around, what needs to happen next. But sometimes if we can get out of that crisis mode and get some resources together, we can really help a person get to a better place. So there's a lot more that can be said about that. I guess I'd be interested in any questions, comments, experiences that anyone in the group here has had. Jason, Sarah, I don't know if you want to do this with just letting people unmute themselves and talk. That'd be the better way to do it. Or if people want to chat something in, that's fine too. But
no, I'm fine either way. If anyone has any questions,
anyone have input or just questions about kind of how, we can't get super specific here, but we at least wanted to talk about this is a real thing, and it absolutely can affect the environment of a house, and these challenges can affect someone's ability to recover. And level of care is really important about what can we do and what don't we have the capacity to do.
Yeah, this is LaShanda with Washington Care Connections. Okay. And so we house a lot of individuals based off of their needs. And so I'm really happy about this. But one of the challenges is not only like them not understanding the circumstance of them having to leave the home because maybe they've never truly had to really have to live up to a condition. And that's something that I've seen is that in a lot of my clients, if they've had to leave a home or if they're off the program because of their decisions, then they get a wake-up call, but it's too late. Are there any things that you guys have in place in these particular homes, or in order any types of things to support reality-based notions that, if you have this particular behavior, this is the outcome that's going to happen, or the consequence is going to happen, to gently remind them about what it's like to truly be in the community.
Yeah, that's a great question. So I would answer in two ways. One is, I think to have a really good set of guidelines around what it is that the behavior that we expect from residents. So, respect for one another, that there are quiet hours that need to be observed, that everyone does their chores, that people don't, that they have a clean, orderly environment, that all these kinds of things that we want people to be able to, that are kind of signs of a functional kind of lifestyle, right? And so if there are ways that up front all of those things can be articulated, and my colleagues will tell you that I'm not a big fan of rule books that are 2 inches thick, because I think that's just overwhelming, and people don't read those, but if you can make it super succinct, but make it really clear that, yeah, this is an orderly environment that has some structure, and that's for everybody's good. And so when someone's sort of outside of those lines, it creates chaos. And so another thing I would say related to that is when someone starts to exhibit behavior that feels like it could be problematic over time, especially if it grows, I want to be in conversation and get to know and build trust with that person as early as I can. The goal being that then when it is time to have the harder conversation, we're in relationship, and in the context of that relationship, I can be a lot more honest, and I can say what needs to be said, but we can do it. It's possible, and someone might accept that feedback better. The other thing I'll say is that if it comes time, if it is time to remove somebody, well, I'll say it this way. The other thing that you could do at the beginning is kind of a preventative, kind of looking forward kind of measure, is to have a plan with residents when they come in, either around returning to use or around mental health issues, to say, is there a support person that we should call if this issue gets the better of you? Is there someone who you really trust in a crisis that could really be a helpful person in this kind of situation? So you're planning, and pardon the language, but I like the way this is, there's probably a better way to say it, but you're planning in a time of sanity for a time of insanity, right? You're planning in a time of kind of normalcy for a time that's not normal. And so I know a number of operators who have those plans in place, so that when something starts to go off the rails, it's not a surprise when I call in somebody who can be helpful. And I want them to be a part of that decision whenever possible. But I had a resident recently who said, yeah, my sister is who is really used to helping me out when I'm in this situation. Great. I want to know that. I want that person's number. And we had to call his sister recently. And that was a real benefit. And she was able to, they had a trusting relationship. She was able to come in and say things that we couldn't say, and help this person kind of find some stable ground. And that was really helpful. So that's the best. I think maybe the theme around all of that is thinking ahead, and trying to kind of prepare people so that we're not always reacting, but we're responding in a way that we've kind of thought through in advance.
Yeah, and
hopefully
part of
that's
that,
helpful, Ashanda.
yeah, and part of that I'll touch on. Alan, that's a very, very great analogy. The best offense is a great defense, and a lot of times when individuals are moving into our recovery residences, it's one of the best things is that I can share is do your due diligence when you're interviewing that individual. If you have to, just ask a lot of those pointed questions. When I'm interviewing individuals, how I always start out with, how is your physical health? And then the individuals, a lot of times my physical health is great, or that they'll have some small ailments that they're dealing with. Then my follow-up question is, how is your mental health? And a lot of times they'll divulge to you, my mental health is great, or my mental health is fragile. Well, what are some of those challenges that you're facing? What kind of recovery are you in for your mental health? What are some of those services that you check into? What is your support systems look like? Just be sure that all of those things are there and in place, and that you can thoroughly go over with the individual their medications that they're on, the services, their wraparound services that they currently have. It's great to be able to assist individuals with co-occurring challenges, but again, if you're gonna, some individuals had posted on there that they were, Max had posted about receiving some residents from Western State Hospital or Eastern State Hospital, and it's great to work with those with those individuals. But if you just want to be sure that you've got the support systems there and in place within your program, that you have staff within your program, or that you've partnered with somebody in your community to be able to provide those services, if that's the demographic and the population that you're going to work with. Again, you just want to be sure that you have partnered with or have the staffing there directly within your program to be able to treat those individuals in their time of need.
Yeah, absolutely. Any other questions, thoughts about co-occurring challenges? We have other topics we want to get to, but and that's certainly not an exhaustive kind of look, but we did want to touch on it just to say that it's something to really think through. If not, we can move forward, and then you can chime in along the way in any of this. So
sure. Next, I'm going to talk a little bit about medication for opioid use disorder, and I'm also going to talk a little bit about MAT, medically assisted treatment. Medically assisted treatment is treatment for opioid addiction that uses medications, and there's a wide variety of them: buprenorphine, Suboxone, methadone, Vivitrol, to treat addiction to short-acting opioids such as heroin, morphine, codeine, alcoholism, as well as synthetic opioids, including oxycodone and oxycontin and hydrocodone. MAT operates to normalize brain capacity, block the euphoric effects of opioids, and relieve some psychological cravings, and normalize body functions without the negative effects of the short-acting drug of abuse. Usually patients who receive treatment for opioid treatment programs, or commonly known as OTPs, are required by federal regulation to receive medical counseling, vocational education, and other assessments and treatment services, and in addition to the medication for the opioid addiction and or alcohol misuse. Let me see. Buprenorphine can also be dispensed in an opioid treatment program. Opioid treatment programs are any treatment program certified by the Substance Abuse and Mental Health Services, also known as SAMHSA. MAT and MAR has been around for some time now. A lot of in line with the recovery residents as a whole. There's been a lot of stigma around the two. A lot of us have heard stories out there. A lot of the recovery programs, they used to preach, oh, you're just trading one substance for another, or you're not truly in recovery if you're receiving medically assisted treatment, or if you're on any of the MOUD drugs, you're not truly clean. And to be honest, when medically assisted treatment first came out, I was very skeptical, if you will. We started to get a lot of complaints from the recovery residences, from the individuals living there, that there were individuals that were sitting on the couches that would be nodding off or triggering other individuals that lived in the house. There was just again a whole lot of stigma around them. And again, in my years of working with individuals living in recovery residences, a lot of it was just that, unfounded stigma. For me personally, I've worked with a lot of individuals that have had a lot of great success with medically assisted treatment, with MOUD drugs. I'll touch a little bit on what medication assisted treatment is. Medically assisted treatment, MAT, is a treatment for opioid use addiction that uses medication such as methadone, buprenorphine, Suboxone to treat addictions to short-using opioids. Methadone or Suboxone, when used as MAT, can only be dispensed the methadone can only be dispensed in an opioid treatment program. Buprenorphine can also be dispensed in an OTP. OTPs are any treatment program certified by the Substance Abuse and Mental Health Service Administration, known as SAMHSA, to conform with Title 42 of the Code of Federal Regulations, CFR Part 8, to provide supervised assessment and medication-assisted treatment for patients who are opioid addicted. An opioid treatment program can exist in a number of levels of care settings and include, but not limited to, intensive outpatient, residential, and hospital settings. I want to talk a little bit about federal law and how those rights apply directly to individual. Federal law prohibits discrimination against medically assisted treatment for opioid addiction, also known as MAT. MAT includes medications, again, buprenorphine, methadone, Suboxone, oral naltrexone, Vivitrol, all that have been approved by the U.S. Federal Food and Drug Administration for opioid addiction, detoxification, and maintenance treatment. When this class of drugs was first approved by the FDA, it was approved only as a step-down program, meaning that there was a very short period of time that an individual could be on these, and then individuals would ultimately have to get away from the substance. Those regulations were changed as they found that some individuals that started this program and then were forced to come away from it would relapse and return to active use. The FDA later approved a program, a maintenance treatment program, if you will. And there's some individuals that are on medically assisted treatment that will have been on it for some months, and others that have been on it for some years. Again, in working with the individuals that I've worked with in the recovery homes, I've personally witnessed a great deal of individuals that have had a great deal of success with medically assisted treatment. I've known some individuals that have been on it now for years and years. Some of them have great jobs here in our community. I know individuals that work for the state. I know individuals that are in medical positions, work in a medical capacity. I know individuals that own successful business owners here in our state. I only bring that up because that is part of those individuals' recovery stories. They've had a great deal of success while being on MAT and MAR. And most importantly, when given the right dose, you would not even know that an individual is on the MAT and MAR. A lot of the a lot of individuals out there, it's becoming less and less today, but individuals on MAT often face discrimination despite laws that plainly prohibit it. The discrimination is largely due to the lack of knowledge around MAT, the value of it, the effectiveness, and the safety, and a lack of knowledge about the anti-discrimination laws that prohibits people on MAT from being discriminated against. Discrimination is also common because people on MAT frequently do not have the tools necessary to educate employers, landlords, courts, and others about the relevant legal protections that they're afforded. When it comes to housing, especially recovery housing that we all deal with, the Federal Fair Housing Act is very clear, and it makes it illegal to discriminate in housing or real estate transactions because of someone's disability. People receiving MAT are protected from housing discrimination under the Federal Fair Housing Act, just as people from other disabilities. More information, if you want to read up on this, I'm going to kind of do a high-level overview today. If you want to read up further on this, the SAMHSA website has a great packet that's out there. A lot of the information that I'm quoting directly from today, recovery from alcohol and drug, it's called Know Your Rights. Housing discrimination related to MAT sometimes arise in the context of residents and individuals in recovery. Individuals who live or want to live in a halfway house, recovery home, or other residence for individuals in recovery are sometimes excluded because of their participation in MAT. I can't stress the importance of this enough, that this is illegal, even though this type of discrimination continues to occur with some frequency. There's been a lot of court cases across the United States where individuals have actually taken recovery residence operators to court, claiming that they have been discriminated against because they have not been allowed to take part in medically assisted treatment programs or to be allowed to be on medically assisted treatment of the various different kinds. To my knowledge and to the research that I've done, all of these cases have quietly been settled out of court and haven't made it all the way to trial. But again, guys, I can't stress the importance enough that medically assisted treatment and medically assisted drugs are truly a form of recovery. They're saving lives. They're helping many countless individuals out there who wouldn't otherwise have the chance at recovery. A lot of individuals, they will go sign up for some outpatient classes. They will go sign up for some inpatient classes after their assessment is done. They'll get to treatment. The treatment providers, the doctors there that they work with, use this methodology day in and day out, again, as a tool to help individuals get clean and sober. It's, again, not only illegal, but it's not fair to the vulnerable population that we work with and that we serve, for individuals to go and take part in this treatment if they're only for them to get out. And we've all heard the horror stories of some of the housing providers out there that no, we don't accept that, and you're not allowed to live here. Again, I can't stress the importance of enough that everybody looking for housing in a recovery housing model should be afforded the opportunity to take these substances. And again, it's discrimination and against federal law. Federal discrimination relating to MAT sometimes arises in the context of residence for individuals in recovery. Individuals who live or want to live, again, in halfway houses or other treatments should be afforded that right. The Federal Fair Housing Act applies to residents, again, such as recovery residences. They fall under the FHA's definition of a dwelling. Individuals in MAT are protected by the FHA. They are also protected by the American Disabilities Act. If the resident receives state or local government funding, and by the Rehabilitation Act, if the residence applies if the resident living there applies or is taking buprenorphine, Suboxone, or any of the other drugs that I had mentioned. Many people also regard people on MAT as having a substantial limiting impairment. Who is not protected? So there's definitely the flip side of this that I want you to be all aware of as well. People who are not protected, people who are currently engaging in the illegal use of drugs, are not protected under these discrimination laws. For instance, if individuals are using cocaine or any other substance in your home that they're actively using that, this federal law, again, does not apply to them. Please note that even though federal anti-discrimination laws generally do not protect individuals who are currently engaged in the illegal use of drugs, they do protect some individuals from discrimination by healthcare providers. And again, the MAT and MAR protections are there primarily for our individuals that are graduating from inpatient, outpatient, or any other means when moving into a recovery residence. Meaning, again, it is illegal, and recovery residence operators should not discriminate against those individuals that are moving in. But at the same time, if the individuals are using any other illicit substance, they can't run to an attorney and claim discrimination against your organization if they are still using and abusing illegal substances. Again, I'm not not a lawyer by any stretch of the imagination, just worked in this field long enough to know and seen a few cases arise from individuals that have really pushed the issue of being discriminated against because of their use of medically assisted treatment or being prescribed medically prescribed the drugs for opioid use disorder or alcoholism. I could go on and on about this today, but does anybody have any questions directly related to MAT, MAR, or the use or acceptance of those in recovery residences?
Jason, I wonder if you could speak to some of the difficulties that operators encounter with people who are using MAT in their homes. If you could talk about just ways that we can be effectively kind of help them manage those.
No, exactly. A lot of times the individuals, especially when those that are first getting prescribed medically assisted drugs, just like when you get prescribed any other medication. Sometimes in the very beginning, it's a trial and error. Medical practice isn't an exact science. They don't get it right each time, every time. And sometimes that takes a little bit of trial and error, though it's a tool that's out there and a great tool that we can have. If you see the individuals, or if there's individuals that are living in your residence that don't have the right dose, perhaps it's having absolutely no effect on them at all. Perhaps they're coming to you and saying, hey, I'm on Suboxone, but it's a very, very low level and it's not working for me. Or sometimes you'll have individuals come to you with just the opposite of that. They start out at far too high of a dose, far too high of a milligram, and individuals are coming to you, hey, we have somebody that's sitting on the couch and they're drooling all over themselves, or they look like they're nodding off, or they're triggering other individuals in the house. there's absolutely nothing wrong with sitting down with that individual on a one-on-one basis and having an open and honest communication with them and helping them quickly get an appointment set up with their prescriber. Having an open and honest conversation with their prescriber that, hey, this is what's going on. These are the symptoms that I'm experiencing. Can we talk about getting my dosage lowered a little bit, or I don't quite feel it's effective. I'm not noticing anything from it all to getting that raised. One of the things that we always want to keep in mind, yes, it's illegal to discriminate against these individuals and having them in the home, but at the same time, we want the other residents in our home to feel safe. We want them to feel secure. We don't want it to disrupt the otherwise normal day-to-day running of the house. And if individuals' medication may be too high and it's triggering other individuals there's absolutely nothing wrong with having that conversation and encouraging them to get in to see their physician and get on, perhaps get a lower or higher dose prescribed to get them on a normal, even keel. Like I said, in the years I've been doing this, I've known a great deal of individuals that have had a great deal with success from it. And individuals that are on the right level of medication, you're not even going to know that they're taking it. And again, sometimes it's just medicine as a whole is a practice. Sometimes it's trial and error in the beginning, and every dose for every individual is going to vary a little bit.
Thanks.
You bet. I know there's at least one physician on here who works day in and day out with prescribing different MAT drugs. If anyone else has any other questions, I'll do my very best to answer them. And
Jason, yeah, just as a physician, I support what you're saying, and probably the biggest challenge right now is the fentanyl. Transitioning from fentanyl to Suboxone is real kind of dicey, and it's hard to get it exactly right. So sometimes just making that transition, you have to use some other medicine temporarily just to help the nervous system to settle down, because fentanyl seems to be metabolized in such a way that it hangs on for a while. And so it's not as easy as going from heroin to Suboxone, which is relatively straightforward. But in response to what you're saying, I absolutely support the idea of medically assisted treatment for those individuals for whom it's appropriate.
Thank you, doctor.
The WAQRR website has a resource. I think it's still on there. It's the NAR has kind of a best practice guide for operators. So if as Jason says, legally we need to accept folks who are on the medication. We also need to be prepared to support them. So if it's just one approach would be to say, well, people are on the medication, they're doing what they need to do, and it's none of our business what they do, and how they manage it is their own affair. And I would say that that's because they're living in a community environment, that's an inappropriate response to what we to the way that we work with our residents. So and this is where a little bit controversial, because not everyone would agree with what I just said, but I would be much more in favor of like Jason said, establishing a really close relationship with the residents so that we know what they're doing. There should absolutely be guidelines in place about leaving medication sitting around for other people to find. It should be really clear what people are, what residents are taking. That's also true of mental health medications and all of that. So our operators are required to have a really good medication policy. We don't dispense medication for sure. That's not our deal if we're not a clinical facility. But how we help residents kind of navigate, for some of them, this is the first time they've done medications in any kind of responsible way. And so to help them navigate that well, And it's okay to have a policy that says that residents will use medications as prescribed. And if they deviate from that, then that is absolutely a worthwhile conversation to have. Because these are serious, there's serious consequences for taking medications. I'm talking more broadly now than just about meds, but mental health meds. Others, sometimes residents are used to kind of managing their own. And we really want to strongly advocate for them to be in close touch. If they feel like they need to make a change, then getting in touch with their prescriber to do that in collaboration with that person is just really, really important. And so it is absolutely our business at some level to know some things about what our residents are taking and how they're managing that medication. A lot of folks do a really good job of it, and so it doesn't affect anything. But when they start to sort of experiment or color outside of those lines, or we have folks who will kind of, they'll do things like not take a particular medication for 3 or 4 days so that they can take it all at once and experience something in the way of a high when they take it. They're just those kinds of things that people will do that aren't taking the medication as prescribed. And so as operators, it's really important that we have some connection to kind of what's going on there. And those things, I think I'd summarize too what Jason said, that holding people accountable for their behavior is kind of our best avenue. In other words, we're not doctors. We need to stay on our own lane. It isn't our business how much medication people are taking. It is our business if they're nodding off in meetings and causing a problem in the house. So that's where we would talk about it. We'd say, well, I don't know what's going on. A typical conversation for me to have would be, I don't know what's going on with your medication. What I do know is that in house meeting, it's really hard for me and other residents when you're asleep during the meeting, and so that can't happen here. So what do you need to do in order to navigate that differently so that doesn't happen moving forward? And that sets up the partnership with their prescriber, their provider to really correct. So anyway, so that's my 2 cents on our experiences over time doing this as well.
Holly, did you have a question?
Or it's Lashanda, is that right?
Yeah, it was Lashanda. Yeah, both Holly and I are in the meeting, but yeah, it was me this time. So no, my point was just that, as you were talking about, it's a trial and error, and what I'm finding is that if they have a follow-up appointment, is because the doctor needs to know what's going on, and that higher level of communication, and building a trust with the client is like, if something's not going right with it, if you're feeling those things, that's why it's important that you keep your follow-up appointments with your prescriber.
Yeah, absolutely. And I think that the doctor would agree. A lot of times today with the caseloads and the amount of clients that the physicians have, sometimes a follow-up appointment can't, sometimes that appointment is 2 weeks away, 3 weeks away, a month away. And if the individual that is on the various different medications is starting to see signs, or us as providers are starting to see signs, or other residents are coming to you in reporting signs, there's absolutely nothing wrong with encouraging that individual to call in and have a conversation with the physician's assistant or the staff there that the doctor's put in place. And 9 times out of 10, a message is going to get to the doctor, and sometimes the doctor will report back that it's okay to lower the dosage of that, or to have that raised. But again, it's just good communication is always a great practice to have, not only with the individuals that are on the medication, but with the doctors that are prescribing it. As long as there's open communication and open dialogue there, again, it's great to have, and that usually can be quickly resolved. Is there any other questions at all around around medications for opioid use disorder that I might be able to answer for any of you? All right. I want to thank all of you for the great dialogue and in going back and forth. It makes it a lot easier for us as presenters when we have good robust conversation around these topics. And just because we're bringing these up today and no other questions come up today, if you guys have questions that come to mind later on, we're here for you. Myself, my team, we might not have all of the answers all the time, but one thing that I can assure you, if you send us an email and we don't have the answers, I will do my very best to research it and be able to get back to you guys with the most up-to-date information. Kind of around this topic, but a little different, is the return to use policies. I'm going to turn it back over to Alan. Alan will touch base a little bit on our return to use policies.
So I mentioned earlier in the day that there's kind of a spectrum of responses to when a resident returns to use, and all of you know that can look like a lot of different things. For some folks, it's just they dip their toe back in the water for a minute, and often the response to that will be, "Wow, I'm done. I don't want to do that again. That didn't taste good. It didn't feel good. I didn't like the way that felt," and so that you know, you could even call that a lapse instead of a relapse, where somebody just tries it on for a minute, and that can be a great learning experience for somebody. And then of course there's the full spectrum where on the other end of that continuum somebody you know, gets sort of drawn back into, maybe because it's the lifestyle or because of a crisis that happens or something, and that can lead to, you know, a prolonged kind of pattern of use. And so our response, I'm going to contend, is dependent on the situation, or should be. So what I'll call, kind of from moving forward, kind of the 15-minute rule, which is what some kind of the traditional way that recovery residences have done this is boy, if you use or come home under the influence, or there's drugs or alcohol in the house, whatever, any of those categories in any way, you've got 15 minutes to pack up your stuff and you are evicted from the home. And that eviction might be, you know, talk to us in 30 days, or it might be permanent or whatever. So that would be kind of on the extreme of the spectrum. And I'm here to advocate, really, to say that policy, generally speaking, is not in the best interest of our residents, and it doesn't take into account any kind of variation about what could be happening in that person's story. And the other thing that it assuredly does is it removes almost always the community that can be really supportive of a person in the time when they really need the community the most. So when a person returns to use, again, even if it's just kind of in that lapse category, to be able to process that with somebody, to be able to have support, to have someone who's been there walking alongside them, whatever, that can be really, really helpful. Does that mean that they get to stay in the house in the immediate, maybe while they're under the influence and acting in a really destructive way, or a way that's really triggering to other people in the house? Well, that's a different kind of story. That's a different question. But our encouragement, we're not going to prescribe a policy here, but want to encourage you to think through a really clear policy as best you can ahead of time, because this stuff a lot of times happens in the middle of the night, and someone who's on the ground is going to have to make a decision about what's supposed to happen, and so that person needs to be prepared with what the response is going to be. And so the question about, there are a couple questions floating around. One is, does the person still have residency in the house, even if they're asked to leave for a short period of time? Another question is, if a person is asked to leave, do they get support in terms of where they're to go? And is there a place for them to go that is safe, that isn't going to sort of lead them back out deeper into the world of addiction that they left, that they wanted to get away from? So could there be a policy in place that says if you're demonstrably under the influence and it's disruptive to the housing environment, kind of by definition, we're going to ask you to leave, but here's where we're going to take you somewhere, or we're going to be sure that you are taken somewhere that is safe. Maybe it's local detox if they qualify for that. They don't always. Sometimes that doesn't work because especially if it's just a short-term use, they may not qualify for withdrawal management. But is there some place that they can go? Is there a sobering center? Is there a family member? So that plan that we talked about a little while ago, what happens if you return to use? Is there someone who we can call that could give you a safe place to be? And then while they're out of the house, can there be, should there be a way that they're communicating regularly with the staff of the house or the house leader, peer leader, whatever, someone who is just regularly in touch with them for that few day period where they're in a really fragile state? How can they stay connected to the community in a way that's safe for them and safe for the community? What would a good policy be that has those pieces in place? But I love hearing from our residents who go through this. I've never been through a relapse before with support, where people haven't just abandoned me and just let me be, let me just sort of go adrift. Because when I go adrift, that doesn't go well, you know. So how can we protect? And here's the tension: how can we protect the requirement that we have and the safety that we have in our homes that are indeed sober environments, while still doing what's best, if at all possible, for the individual involved? And that's the tension. And those things compete with each other sometimes. And so how we handle those are really, really important. So want to encourage you as you're kind of thinking through not only policy, but practice about that. The other thing, so the first question was around sort of their status in the home, whether they're evicted or not. And so we have kind of in our policy, for example, kind of split that out. And we say explicitly, if we ask you to leave the house because you're under the influence for a short period of time, you are not evicted. That is not what we're doing. We will protect your belongings and they will be here for you. And then we will discern together if you're coming back to the house, when that will be, and that you've got a place to live. And so that just kind of immediately lowers the anxiety level for a person and can really help them focus on their recovery instead of having to think about their things and having to think about they no longer have a place to live, any of that. So being able to make the appropriate decisions in the appropriate time frame can be really helpful. So this issue is kind of a sticky wicket, and so I anticipate there are questions, comments, suggestions, feedback that you all have who have been doing this about the way you do it. Really like to kind of open up the dialogue at this point and just ask if anyone wants to join the conversation and challenge anything I said. That's totally fine, of course, but also just want to hear back from folks. So anyone have anything they want to add? If so, I'll let Jason or Sarah call on you.
Holly had a question. How does that work for clients with housing vouchers?
Yeah, well, that's sort of between the agency that's giving the voucher and the resident and the operator. As far as I'm concerned, so I'm speaking with an operator hat on now. If I'm an operator and somebody relapses and chooses maybe to leave the house, we've tried to talk about coming back and they decide, hey, I'm not coming back. Sometimes they'll ask for a prorate or whatever. Those funds go back to the organization who gave the voucher, is what we would do. Voucher funds would never go to a person. Sometimes that organization wants the voucher back. Sometimes they'll say, hey, if that person was here any part of the month, then the housing operator is entitled to the voucher. I just decided years back not to die on the financial hill there. If somebody leaves and has a supportive environment to be in, and a refund to them, this is not vouchers now, but this is for individuals who paid themselves, a refund to them in the partial amount, a prorated amount, help them in their next stage, and isn't going to, be destructive to them, I'll often grant that. So I just don't, I never want to be accused of the money being the main thing. And so that's our own kind of philosophy here. Someone else may operate differently. Certainly wouldn't probably give money to anybody who is in active use. That's not a good use of, that's not good for them ultimately. But in terms of vouchers, it really is, that's a conversation I typically would have with each sort of individual organization that's providing the voucher, about what their expectation or hope would be for it. I don't know if I got to that, Holly or Lashanda, but hopefully. Other questions or comments, feedback, really open to what folks are doing that's been successful for you all in these processes. They're tough, and they're often case by case kind of decisions that we make.
So Alan, this is David Nielsen. I'm in Colville, Washington, where we've got about 5,000 people, and there's literally no resources. So we don't have recovery housing yet, but as I'm thinking about what the model would look like, if I was to put somebody out on the street, there would be literally nothing. So I'm wondering, is there like a quarantine model or something where you could keep, what would that look like?
Could do that. You could have a space that's set aside in your home. Maybe it doesn't have a sign on the door, but what it's for. That maybe it's a little bit more self-contained, and basically you achieve the balance. You can maintain a sober environment for the rest of your house. This person is getting care and attention that they need in order to do their withdrawal management or whatever it is that they're doing, in order to get to a safe place, to be able to make decisions with a sound mind. All of that that could totally happen.
Okay.
I wouldn't advocate for a model that says, hey, let's just pretend nothing happens, and you know what I mean? Because that could send a message to your other residents that it really doesn't matter. And we're trying to say, actually, sobriety does matter. We are an abstinence-based house. We want to maintain that. So something special happens. And in your case, kind of in an extreme situation like that, I can see where you could definitely make the case for a probably call it something different than quarantine, but like a special care model or something like that. Yeah.
Good. Thank you.
Yeah.
And there's actually, David, there's a lot of talk going on right now with some within the state of what some funding might be able to look like if an individual has to leave the home and they have to go to detox, or they have to leave and they have to go to an inpatient treatment program, what that might be able to look like to be able to get the cost covered for their bed while the individual goes there and is able to take part in that treatment. So there's a lot of great stuff that's in conversation that's going on.
And another version of that would be that maybe some of us operators who have a lot of homes may be able to set up kind of respite spaces for people who are either waiting for a bed or maybe because the house isn't set up for it, like you described, doesn't have a spot, but they need a spot. So maybe it's a couple towns over, someone can just go and be in that safe place in another residence for a bit until they're in a place where they're ready to come back. Something like that, and that would be a really helpful thing as well in the system.
All right, Barry. Sorry, Barry is raising his hand for a question.
Right, go ahead, unmute yourself. And
yep. Hi, this is Barry. So David and I have been in conversation about clean and sober housing. We represent different organizations, but we really want to collaborate on this, so we're not duplicating. We're using our resources appropriately. And I guess one of the questions that I would have is, could you do a comparison Oxford model versus a level 2 recovery residence? Just kind of the basic differences. When I just talked to Stacy, who knows Jason personally, and Stacy's actually going to give you a call, Jason. And by the way, David is going to be joining us, Jason, on the 15th when you come up, as well as one of the representatives from rural resources. So we'll have a chance to talk a little bit more about this, but just a comparison. My understanding is that it's much more peer run, that it's immediate kind of expulsion. That's the model they use. And it's democratic. And the degree of support is very dependent upon the Oxford organization, which is it could be seen as a bit of a weakness, and they admit that. So would you mind just kind of thumbnail sketch of what the differences would be and what the advantages of one versus the other? Because obviously, as David said, we got nothing up here.
And Jason, you want to take that?
Sure.
And also, would you want to start
Yeah.
with the topic we're on and then work more broadly? Does that make sense?
Yeah,
So-
no, absolutely. So the great thing, Barry, within the WAQRR accreditation, we allow for our individual operators to be able to come up with their own policies and procedures, what that looks like around recovery housing. As Alan advocated and spoke on, and I 100% advocate for as well, is that we're able to come up with contingency plans, that we're able to come up with somewhere for that individual to go in the case that relapse happens. Oxford has a very steadfast rule, policy, and procedure in place. If an individual relapses, 9 times out of 10, they hold a meeting as soon as possible, and an individual has 15 minutes to get their stuff together and go. After that individual is able to achieve 30 days of continued sobriety, or in very selective cases, after they complete some inpatient treatment, they are allowed to then and only then to return back to a recovery residence. In most cases, not the recovery residence that they have just left from. They take the stance that clearly something was not working there when they were there before, so they do not allow them to come back. As Alan talked about, that they do not allow them to come back to the same residence. As Alan touched on, and I'm 100% in favor of and advocate for, is that we come up with the contingency plans. A good majority, I will say, of the recovery residence operators that we accredit have policies and procedures in place, that if an individual relapses, they're willing to have open and honest communication about what took place there and how it can be avoided in the future. We will do what we have to do to not only protect them, but to protect the other individuals that are living in the home. David had touched on, if there are no loved ones that they can go stay with for a few days, if there is no place for detoxification that we can get them into, if there's not another safe place that we can get them to for 3-4 days to be able to get that out of their system, so they're not triggering other individuals in the house, for lack of better words, a quarantine room or somewhere that can be set aside. There has to be some consequences for the relapse. Don't get me wrong. Whether that's increased meetings, whether that is getting another assessment done, whether that is having an open and honest communication with their probation officer, with their treatment provider, with their physician that a relapse happened, whether the housing provider mandates that you're going to go do 30, 60, 90 meetings in the next 90 days, whether that's sitting down and coming up with a good, hard, steadfast relapse prevention plan. Basically, we're just trying to come up with stuff to how do I want to say, we're looking for ways to come up with a plan with that individual so relapse doesn't continue to happen. That when they start to have those feelings, that they're, as we all know, or most of us know, relapse isn't something that just happens spontaneously. Relapse is something that happens in the mind, usually a long time before the active use picking up happens again. It's just identifying those things and helping the individual to be able to identify them to get past it. But I mean, Alan and I 100% agree on this topic, that just because somebody relapses doesn't mean that you have to throw everything away. It doesn't have to mean that you're homeless again, that everything that you worked so hard to regain has to go out the window. It doesn't mean that. And I encourage everyone to be able to come up with a plan. So when an individual does relapse, this is how it's going to be viewed. And Alan also touched on in the beginning of this presentation that it's that it's on a case-by-case basis. I've had individuals come up, hey, you know what, I was at a party, I messed up, I smoked a joint, I had a glass of champagne, I come home, I feel absolutely horrible about it. What can we do? Well, in that situational case, great. It's not great that it happened, but it's great that they came to you, that they were open, that they were honest, and that you can come up with a plan so history doesn't repeat itself. Again, in my tenure and my years of doing this, I've also had individuals that have come home that have been so inebriated, so drunk. The last thing in the world we want to do is put their car keys in their hand and send them out on the streets and tell them to go drive their car, that they can't be there. If we can get them down to their room away from anybody else and go have them sleep it off, then in the morning we're going to have an open, vibrant conversation about what took place. At the same time, if somebody comes home and they're in a drug-induced psychosis, or they're so drunk and they're acting violently, we need to immediately do what we need to do to be able to protect the other residents in that home. So each case, each relapse, if you will, is going to be situational. But I always encourage.
I think I'm sorry, I interrupted you mid-sentence. I'll let you finish and then.
Yeah, I always encourage individuals to be able to come up with a plan. I'm not at all a big proponent, Barry, as you touched on. Stacy's a great lady, worked for Oxford House for many years. I worked side by side with her, but I too have always thought that was a bit rough and not quite the appropriate stance. Of course, we need to protect the individuals that live in the home, but 15 minutes to get your stuff and together and go, definitely not the answer as well.
It sounded to me, Barry, like your question was also broader than just this particular policy. It sounds like you wanted to know just basic differences between Oxford and maybe a level 2 home. And I think just goes back to, just for the sake of time, I'll abbreviate it, but it goes back to just level of care, and that the Oxford in a level 2 home or higher level 3 or level 2 home with higher level of care, there's some sort of external person, there's a policy that's consistent. There might be somebody else making the decision about who comes in the home and what happens in this kinds of situation that we've been talking about. So really, so it's about level of care. So if your community is looking at, hey, we can have one kind of recovery home in our community, given the resources that we have, what should it be? So then I think the question is, what's the needs assessment here? Is it, do you have an inpatient facility nearby from which people are coming? And are those people, do they often have recovery capital or not? Are there other resources? If it's the only place in town, or in, if it's in Colville, my guess is there's not a lot else going on in terms of level of care. So you may shoot for a higher level of care because you get one shot at this, and you're working with folks who are coming out of maybe in institutional environments, either incarceration or treatment, who have maybe very little recovery capital. and you get one shot at it, boy, I don't know that I would do an Oxford there because you probably, a number of those folks are probably going to need more care and connection. And so then maybe later on an Oxford opens up for the graduates of that program, that you start with a higher level of care, and they want ongoing support. Now that they've built some recovery capital, then it's time to talk about having an Oxford. I'm not sure I would lead with an Oxford or a low level 2 kind of a house. But anyway, that's a conversation that Jason or I would be glad to have with you outside of this meeting. But is that helpful?
Yeah, it's really helpful. Just a comment about that, in terms of our medical model here at my clinic, we provide MAT, and we're committed to that. But, just conceptually, when a person relapses or has a urine that doesn't fit with, their prescriptions, what the accountability piece is to bring them in and have a face-to-face, like we draw them in. And I have to sit and look at them eye to eye, and I have to hear where their heart is at. I have to understand, what their level of commitment is. And we just kind of tighten things up a little bit in terms of the accountability. So I see them more often, or I talk to them more often. And we may have a kind of a shorter time frame in which we see them, and we make sure that they have the support that they need. So it's an opportunity to really help a human being to be more accountable and to really change their life and try and help them through this transition. So I think that that's really what you're describing to a large degree. So yes, that's very helpful.
Great.
Does
Anything
anybody
else on this topic? Yeah, we can go along, but you can tell this one has a lot of nuance to it. It really does, and it takes some real discernment to figure out kind of where you're going to be on this one.
All righty. We will move on to our WAQRR accreditation process, and with that, I'm going to turn it over to Sarah, and Sarah is our assistant of accreditation here at WAQRR.
Hi, all. Happy to be here to talk about the accreditation process with you all. One of the things I want to highlight that's important to do prior to even collecting your documents and applying is to really take a good dive into our website, really get familiar with our standards. I think that's really important when you're going to write up your policies and procedures. And so with that, we have 3 main phases of the accreditation process. The first is the document and program review. From there, we do the the provider interview after the document review. And then the final phase is the site visit. So the first step is to complete an application and submit all the documents through the online WAQRR portal. And that can be found on our website at www.waqrr.org. And at the start of the application, you're going to be asked to estimate the level of care that is provided in each of your homes, as Alan discussed earlier. Most WAQRR accredited homes are level 2 or 3. And so prior to or after you submit all your documents and before they go to a document reviewer, that is when we will collect the funds, the membership fee, and the accreditation fee, and that can be found on our website. And it's under a WAQRR accreditation fee schedule. So, but yeah, like I said, the funds are collected prior to releasing the document review report. So the documents are reviewed for compliance with our WAQRR quality standards. Our document reviewers are not the final decision makers, but information collectors who recommend follow-up actions to the accreditation coordinator, either myself or Brianna Yoakum. We have criteria, and each required document component is reviewed according to the latest version of our standards. They're listed either 1 through 3. So 1 is the component does not meet part or all of the standard. It is either missing or does not meet the basic intent of the standard in question. Number 2, the component is present and meets the intent of the standard in question. And then number 3, that just means like you went above and beyond what we asked, everything looks great, and we're all set there. So once we review the documents in your application, it's kind of a back and forth between us there. That can take a little bit of time because we're just making sure we receive all the documents from you. Everything is according to our standards. So the time on that typically takes, I mean, however quickly, you're able to get those documents back to us. So, but after we receive everything is good to go. We will schedule an operator interview with you. And that's just to kind of take a deeper look and have a good conversation with you about like, what is your vision? What is your mission? What are your goals for your recovery residents? So that's just like a conversation over Zoom that we have. And it's pretty painless. That's something that's the step 2 of the accreditation process. And then after that, we will schedule a site visit, and those will be scheduled after the interview. And they are conducted by a WAQRR inspector, and the results are submitted via email, and those have an inspection criteria as well. They rate 1 through 3 as well. So number 1, the item does not meet the standard. For example, a room is too small to accommodate like 50 square feet per bed in the room. They lack egress windows, that sort of thing. And then number 2 is the item meets the intent of the standard in question. So for example, all furniture is safe and in good condition. Everything looks great. Excuse me. And then number 3, the item exceeds the standard. And this is our way of commending you for an exceptionally clean, safe, and welcoming home environment. If needed, we will communicate what needs to be fixed. And that's sometimes as easy as just taking a picture of what needed to be corrected and just emailing that photo to myself or Brianna. And then once all those requirements have been met, we will recommend the applicant to the certification committee. And after final approval, we will send the certificate and submit the public provider information to be posted on our WAQRR residence directory. So all in all, the process typically takes about 4 to 6 weeks. It's just really dependent on how long it takes for you to get your documents in, the back and forth communication with getting the proper documents submitted and corrected. And so yeah, that takes about 4 to 6 weeks, depending on how, motivated and ready you are. And from then we, like I said, issue the certificate and you go on our registry, and then you have you have the reaccreditation after, so 1 year from your accreditation date, where we go through the program and document review again. It's not typically as in-depth as the initial. We will have another operator provider interview, and then we also do a site visit as the final phase, just to make sure that those standards are still being met. Yes, and so if you have any question, you can reach out. I'll put my email in the chat, but I'm Sarah Carr. You can reach me at Sarah, SARAH, at WAQRR.org. All right, any questions on that? Sorry, I talked so fast.
No, you're good. Thank you, Sarah.
Oh, and also something I wanted to add is at any time during the process, if you're running into trouble, we can schedule a technical assistance meeting with you via Zoom. And that just really like helps us kind of go into more depth of like what you're looking at your on your application, and for you to ask any and all questions. So
I know it's a bit of a heavy lift for those of you who have went through the document review. There is a lot of documents. There is a lot of rules, policies, and procedures in that we ask for when going through the document review process. Again, not only to protect the residents, but to protect you guys as a provider as well. And as Sarah alluded to, if there's questions that come up, or what on earth is does a certain policy look like, we're 100% here to help you guys. We have some sample documents that are available that we can share with you guys, and if you have direct questions that come up during the process, we're here for you. We can do as many Zoom meetings, as many phone calls as needed, back and forth. Our ultimate goal is to be able to get as many approved and accredited recovery residences out there, and recovery residence beds as we can. For the providers that have joined us and are on here today, I know that somebody again from Snohomish County had posted that there's some providers up there that aren't accredited yet. If you want to make a welcome and a virtual introduction between them and myself, or them and our accreditation team, please do so. We're here for you guys. We're here for them to try and make this process, the accreditation process, as easy as possible. Does anyone have any just general questions at all about the accreditation process and in what that looks like, or any other questions that we might be able to answer? Okay. The last thing that we'll touch on for today is our upcoming webinars that we have. Actually, tomorrow we're hosting a 2-hour webinar. We've got some great providers from a nonprofit organization out of Utah that will be speaking on considerations for the LGBTQIA plus community, people of color, and immigrants. They'll touch on cultural competence in recovery residences. Again, that one's going to be held tomorrow from 10 a.m. until noon. If any of you are interested in signing up for any of that, they can be found directly under our events on our WAQRR page. Also on the next day, December 6th, we've got a guide to creating successful partnerships with landlords. This is a toolkit that we developed here at WAQRR that will talk about liaisoning and being able to work with landlords. That'll be again December 6th from 10 to 11:30. Then December 7th, we'll be navigating the world of CBHAs and how to partner and become a community behavioral health agency. Again, another toolkit that we built out here at WAQRR. That one will be held December 7th from 10 a.m. to 11:30. One other announcement that I wanted to make for all of you that are either new to recovery residence operations, or if you're considering expanding what you currently have. The Washington State Department of Commerce currently has a grant out there and available. Their current grant cycle closes on December 15th, but in that they're offering up to $100,000 to get a new recovery residence up and off the ground. WAQRR also has a substantial amount of money. We will be offering the exact same grant opportunity. We will be publishing the same NOFA that the Department of Commerce has published now. We're giving them that again, theirs is open until December 15th. We're just finishing up some final contractual stuff, but our grant opportunity will come available probably the first part of January. Again, we will be able to offer $100,000 to current WAQRR accredited providers that are opening new recovery residences, or recovery residence operators that are currently going through the WAQRR accreditation process. It's a heck of an opportunity. Those funds can be used for basically anything but initial capital costs. They can be used for mortgage payments, rent payments, paying of staff. The funding can be used for such as insurance, maintenance, paying staff to be in those homes. It's a great opportunity, great opportunity out there that is available for those current, again, those that are currently certified by WAQRR, or they're going through the WAQRR accreditation process.
Hey, Jason, Rhonda had a question about that.
Yeah, go ahead, Rhonda.
Thank you. I actually had two questions. The first question in regard to the $100,000 that you just spoke of, is that funding available to use for a down payment to purchase a new house for no?
Unfortunately, it cannot. It cannot be used for the purchase. It cannot be used for the down payment. But after everything is done, it can be used for your mortgage payments, or it can be used for your lease.
And is this for newly acquired homes or for mortgage on a current?
Any home that was acquired on or before October 1st.
On or before October 1st?
Yeah, I'm sorry, not before, on or after October 1st. I apologize.
Okay. Then
Yeah.
my second question is in regards to there's the rent funding for new residents moving in.
Yes.
And I've applied for I had one new individual move in, and I'm just wondering what the timing is, how long that takes to get that reimbursed.
Yeah, so what that looks like when you put in for rental assistance, you have to apply for the assistance for the month that we were in, the month that we are in, and then on the 28th, 29th, right around there, all of those the gal in our organization, her name is Blair. She pulls all of those applications between about the 28th to the 5th. She is processing all of those, and by around the 10th of the month, you will receive your deposit directly into your account.
Great, thank you.
You bet. Holly.
Hi, yes, this is LaShanda again. So a couple questions. Do you accept housing subsidies like OLSA or Section 8, or are you guys, do you have your own subsidy?
So I'm assuming that you're asking your questions from a recovery operator standpoint, and if the recovery operators accept those.
I'm asking the question from a person who makes the referrals, and who
got you,
finds housing for clients.
Got you. So yes, we always encourage, from a WAQRR standpoint, we always encourage all of our recovery residence operators to take a very braided approach to funding, if you will. We always encourage the recovery residence operators to reach out and get MOUs, memendos of understanding in place, or get contracts in place so they're able to accept that funding. With that being said, some of our recovery residence operators out there accept some of the programs that you just talked about. We have others out there that accept all of them. So again, that's going to vary from provider to provider, but from a WAQRR standpoint, we always encourage our providers to take a braided approach to that, if you will, because the more opportunities that we have to be able to serve the clients, the better.
Thank you. Yeah, that answered my.
Okay. Does anybody else have any other questions or follow-up comment? Well, that brings us to the end of our presentation for today. I will gladly give all of you guys back 25 minutes of your day, because I know how hectic things can be, especially on a Monday and around the holiday season. Again, on behalf of WAQRR, I want to thank all of you, all of my presenters that were able to join us here today for some.
Jason,
great.
sorry.
Yes.
Somebody messaged me by accident. Max had a question.
Okay, go ahead, Max.
Hi, Jason. Sorry about that. My
Not a
fingers were a
problem.
little too fast. So I am just exploring this space. I have never dealt with addiction, but I've been in caregiving for a long time.
Sure.
We run an adult family home, and like I said, we wanted to, go into that space, but we also understand that we know nothing but just caring for people. So
Sure.
my question is there somebody we can reach out to for guidance or coaching on further, asking individual questions about what we're trying to do?
So Max, within our network, we have a lot of great recovery residence providers, if you will, and on our WAQRR website, under our list of accredited providers and houses, it will list whom actually each accredited provider in the list of the houses that they have. Max, I would encourage you to reach out to as many and all of them as you possibly can. We're all in this business for the exact same reason, to be able to help individuals get back to living in society on society's terms, and we're all here not only for that, but to help individuals. We've got a great network. If you're going through the WAQRR accreditation process, we've got a networking meeting where all of our providers are going to be getting together. We're going to be holding that first meeting here this month. You can gladly reach out to Sarah. Sarah posted her information there. Max, if we need to have some more meetings, we're more than willing to do that as well. One of the biggest things that I can suggest for individuals like yourself that have got a big heart and want to be able to work with individuals that are in recovery and to be able to provide recovery housing, you're going to want to find yourself a darn good house manager, preferably somebody who's worked in the clean and sober housing realm for a while. Get them involved either on your board or to be able to collaborate with them as you're building out your rules, policies, and procedures, just to be sure that everything is in place, that all of your I's are dotted and that your T's are crossed when it comes to serving individuals of this demographic.
Thank you very much for that answer.
Of course. Yes, you're most most welcome, Barry. We look forward to I look forward to the trip up there to Colville and meeting all of you guys on the 15th. If there's no other questions, again, on behalf of WAQRR, I would like to thank all of you for taking your time out of your day to join us here today. I'd like to thank all of my presenters, my team, my board of directors, and all of you for the great, vibrant conversation that we've had. Again, we've got a lot of great presentations coming up here in the next week. We've got a lot of, if you haven't joined us yet on Facebook, we've got a lot of great information that gets posted there, as well as in our listserv. And a good majority of all of our presentations, if you ever want to look back on them or re-listen to them, they get posted directly to our YouTube page as well. Again, on behalf of all of us, want to wish all of you a happy and safe holidays. And again, thank you for attending. And until next time, be well.
Thank you all very much.
Thank you.